Andate a casa, non c'è nulla da fare. 25 anni fa, una diagnosi di distrofia muscolare di Duchenne.
È vero che i miei muscoli diventano sempre più deboli.
Una patologia degenerativa rara che colpisce i muscoli. Ma c'è chi non si arrende e fonda Parent Project. Intanto il mondo cambia e anche Parent Project cambia un po' il mondo.
Ringrazio Parent Project e le opportunità.
L'ultimo anno finanziato da Parent Project.
Il project che ha circa 8 anni nella prima studiare in maniera...
I pazienti oggi hanno un futuro da immaginare, degli obiettivi da raggiungere e dei traguardi da conquistare. Oggi, anche con la Duchenne puoi diventare ciò che vuoi. Come Luca
Buzzella, che ringrazio per essere qui.
Morire insieme, in fin dei conti, è una sfida già vinta.
I'm here to tell the future is there.
Jacopo,
Alla Duchenne.
Matteo, Lorenzo, Luca, Samuele, Francesco e come tanti altri ragazzi che vivono una vita piena. Ma questo non basta, non c'è ancora una cura e tanti sono gli ostacoli da superare e le strade da aprire.
Tutti insieme abbiamo formato una grande famiglia.
Scrivi i prossimi 25 anni di storia insieme a noi.
Buon pomeriggio.
Good afternoon. Here we are, once again connected to you from our spaceship for the last afternoon of our 4-day international conference organized by Parent Project. It is the 19th International Conference, which this year took place from space on our spaceship, where we moved in order to continue this journey, which started 25 years ago. Next to me, there's someone who needs no introduction at all. The founding father of Parent Project. And today, it's a very special afternoon because with us, we also have Pat Furlong from the US, whom we'd like to greet and thank, because it all started with her. She is the founder, and you're just a surrogate. She is the real founder. With us, we also have a travel companion who's been with us for many, many years. And I'm talking about Professor Fabrizio Racca, whom we'd like to thank for being with us. He's always been by our side, and especially by the side of our families. And he was also in our opening video, just to bear witness to our history. This afternoon, we'll begin with a very special moment because this session is dedicated to management of emergencies, clinical management. I'm talking about the clinical management of DMD, and especially the PJ Nikolov protocol and the history of it, how we got to this point, and the emergency card, which we created with Professor Racca, and which we will have the honor to present to you physically, because we will be sending you a physical card at home. And the floor over to you, Filippo, to begin this session now. And please stay with us, everyone. Thank you, Christina. First of all, let me just further delve into the contents of this session this afternoon. Today, we had the opportunity to organize this session focusing on two interlinked issues. One is the emergency card. The emergency card is going to be filling a huge vacuum because for 25 years, and some for more, we have been taking care of our children. We have tried to establish all the possible relations in order for them to live in peace of mind, with peace of mind and feeling supported entirely. And then, of course, Italy is a long boot. It's narrow and long. There might be emergencies somewhere. And so everything that we endeavor to build is in peril. It's in jeopardy because we don't know what will happen. It really does depend upon the local emergency center, how they are attuned into DMD, and how important what we've done is. And we have come up with two essential tools to fill this vacuum. First of all, the mainstreaming of information, and the other tool is the emergency card. This is a tool that should help us to protect the very delicate phase, which is the passing on of necessary information in order to manage any emergency situation. We're going to delve deeply into this together with Fabrizio Racca, who deals with emergencies in his life every single day, and that's been involved with Parent Project since 2005. He's a longtime friend. But before going into detail and talking about emergency cards, I'd like to ask Pat to very kindly help us to trace back the history of a family that drastically improved the survival possibilities of anyone being treated for DMD or with corticosteroids when they go into an emergency room. The Nikolov family is what we're talking about. We're talking about PJ Nikolov. He is Brian's son, and everything that happened from that day that changed to help the history of this disorder or disease. But Pat, can you help us trace back the history?
Sure. Thank you, Filippo. And it's such a pleasure to be here. Thank you for including me. I think all of us with children with Duchenne muscular dystrophy have had the experience where something happens, whether that's a fracture or an emergency or the flu and an emergency. And if we're traveling or in a rural area, we end up in an emergency room. And usually the people in the emergency room, the healthcare providers, are not very familiar with Duchenne. So that starts a very long discussion about what to do and what not to do. And sometimes that works for families and sometimes it doesn't. When I met Brian Nikoloff, he had just lost his son, PJ. And PJ had suffered with multiple fractures and had been admitted to the hospital. And there was a worry that the steroids weren't continued in the right way. And in particular, that there wasn't a stress dose of those steroids that was given. So PJ died, and it was really so tragic to lose any of our boys. But we thought about this event and what could we do, because the Nikoloff family has been involved in Duchenne muscular dystrophy for even longer than Filippo and I. So Brian spoke to us about what could we do, how could we help prepare families, and how would that work? So we really embarked on a journey of what did that look like. We gathered some experts in the United States like Jerry Mendel, Kathy Kinnett from PPMD, who's a nurse practitioner, and others, Gary Noritz from Nationwide, another pediatrician, and thought through how could we create a card or information that parents could have on board that we could disseminate through the electronic health records and that we could share widely so that families who get into this situation would be armed with information so that they could provide it to the emergency room or to the healthcare professional that they're coming to encounter or they find, and that person would be well informed about Duchenne and be able to act in a way that saves lives. So that was the development of PJ Nikoloff protocol. It has been widely disseminated, and Filippo and Fabrizio, I'm so glad that you're using this. The card has helped numbers of thousands, I think, of families whose children have fractured or been in otherwise emergency situations, so that they have it on the chair, they have it in their wallet, and it's in the electronic medical records. So we're really grateful that you two are spreading this word through your healthcare professionals and through the families in Italy.
Grazie, Pat.
Thank you, Pat. With the involvement of Pat, we asked Brian to help us, Brian Nikoloff, that is, Philip James's father, to please help us to build a project in order to disseminate the protocol pan-European, Europe-wide. The protocol is well known to an elite of scholars, perhaps, and clinicians, but it's not as well known as we would like it to be, at least in Italy. And let's remember that the main vehicle in these situations can be the families, in order to induce all the various local centers to be updated on the information. This is important, the link between the family and innovations that come in, like the Nikolov family, to help us understand that crucial link and that sequence of necessary operations. Fabrizio has a very interesting presentation that he will deliver to help us understand how to help disseminate the Nikolov protocol widely in Italy and perhaps
Ok,
in
buongiorno a
the rest of
tutti,
Europe.
grazie per
Thank you.
l'invito.
Good afternoon,
Sono
everyone.
molto
Thank you for
felice
your
di poter
invitation. I'm
parlare
really
di
happy to
questo
be able
argomento.
to talk
Scusate,
to you about this.
devo rimettere la
I'm sorry,
diapositiva
but I have to
in ordine. Me ne ero accorto.
rearrange my
Ecco,
slides.
ok.
There we
Vi dicevo che
go.
sono molto
I
felice di
was
poter
saying I'm
parlare
really
di
happy
questo
to be able
argomento
to speak
perché
to you about this
le cure in
issue,
emergenza
because
sono, come diceva
emergency
Filippo,
care, as
un
Filippo
argomento
rightly
che mi è
said,
sempre stato
is
caro
a
e che
topic
giudico
that's
molto
always been dear
importante,
to my
soprattutto
heart, that I
l'interazione
think is
tra noi
extremely
medici e
important,
le
especially the
famiglie
interaction
è un
between
po' l'oggetto
physicians
di
and the family,
questa
which is really the
presentazione.
fulcrum of my presentation.
Non posso essere più breve in questa parte. Volevo proprio iniziare con la storia di PJ Nikolov, ma è già stata raccontata, nel senso che lui è un paziente che nel 2013 era trattato dall'età di 6 anni con il cortisone. Nel 2013 fa un viaggio in Florida dove si frattura omero e femore e quindi viene ritrasportato nel nord degli Stati Uniti per trattare le fratture. Nel post-operatorio purtroppo sviluppa un'insufficienza respiratoria acuta associata a una grave ipotensione e in seguito a queste complicanze purtroppo muore. E successivamente i medici che sono stati coinvolti in questo caso, revisionando il caso clinico completo, hanno ipotizzato che la mancata somministrazione di dosi aggiuntivi di cortisone fosse uno dei fattori che aveva concorso alla morte del ragazzo attraverso un meccanismo dell'insufficienza surrenatica acuta. 3 anni dopo una commissione di esperti, come diceva prima Pat, ha pubblicato un protocollo proprio per la prevenzione dell'insufficienza surrenatica acuta nei pazienti affetti da Duchenne in terapia con il cortisone. E questo protocollo è stato dedicato a PJ Nikolov. Il protocollo sottolinea che quando un paziente è sottoposto a una terapia prolungata con cortisone, in caso di uno stress molto importante, ad esempio un intervento chirurgico, un trauma, un'infezione, può sorgere un'ipotensione severa e questa ipotensione severa è causata dall'insufficienza surrenatica acuta. E quindi il protocollo suggerisce fondamentalmente 2 cose. La prima è che in caso di uno stress elevato bisogna aggiungere alla terapia un tipo di cortisone chiamato idrocortisone somministrato in vena. E l'altro punto importante è che non deve mai essere sospesa improvvisamente la terapia cortisonica per bocca. Se ciò deve succedere, deve accadere in modo graduale e il protocollo di Nikolov spiega anche come fare la sospensione graduale del cortisone. Ecco, volevo un attimino però spiegarvi perché è così importante la produzione del cortisolo da parte del nostro corpo. È importante perché è un meccanismo di difesa che l'uomo ha creato al proprio interno. Cioè quando c'è un forte stress, allora è importante che si crei una grossa produzione di cortisone perché questo ci serve ad affrontare una situazione di pericolo. E questo accade perché l'aumento del cortisone aumenta la quantità di sangue che arriva al cervello e al cuore e quindi ci rende capaci ad affrontare uno stress importante. Il meccanismo attraverso cui ciò avviene è che quando il cervello percepisce uno stress importante, allora attiva un asse chiamato asse ipotalamo ipofisi surrene che porta alla stimolazione del surrene, che è questo piccolo, vi indico, questo piccolo organo che si trova sopra il rene, che è in grado di produrre grandi quantità di cortisolo. E queste grandi quantità di cortisolo ci aiutano ad affrontare le situazioni di pericolo. Se il paziente però assume una terapia cortisonica cronica, succede che questo asse ipotalamo ipofisi surrene viene inibito e quindi in caso di stress importante non è più in grado di produrre il cortisolo che ci serve per affrontare il pericolo. E allora può insorgere l'insufficienza surrenalica acuta, che può essere caratterizzata, come vi dicevo prima, da una grave riduzione della pressione sanguigna, ma può anche manifestarsi attraverso delle alterazioni della coscienza o un dolore addominale associato a nausea e vomito. In tutti questi casi è importante agire con una terapia salvavita, somministrando l'idrocortisone endovena e poi somministrando anche dei liquidi. Per prevenire l'insufficienza surrenalica è stato appunto creato il protocollo di Nikolov. E la prima cosa di cui si è occupato è stabilire cosa vuol dire prendere il cortisone in modo tale da inibire l'asse ipotalamo-ipofisi surrene. E questo lo dice molto bene, per dosi inferiori a 5 mg di prednisone non c'è pericolo. Se prendiamo più di 5 mg di prednisone, soprattutto se lo prendiamo per più di 10 giorni consecutivi, allora l'asse ipotalamo-ipofisi surrene viene inibito e quindi bisogna attuare il protocollo per prevenire l'insufficienza surrenalica acuta. Non tutti i Duchenne prendono il prednisone e allora il protocollo ha anche preso in considerazione la dose equivalente. Noi sappiamo che 5 mg di prednisone equivalgono a 6 mg di deflazacort. Quindi se il paziente assume più di 5 mg di prednisone o più di 6 mg di deflazacort per più di 10 giorni è in una situazione di pericolo, qualora sospenda il cortisone. Quindi il cortisone non va mai sospeso improvvisamente e se avviene un evento acuto, chirurgico, traumatico o una patologia medica importante, è importante aggiungere delle dosi di cortisone aggiuntivo attraverso l'idrocortisone endovena. Qual è la dose di cortisone, di idrocortisone che va somministrata in caso di stress? Ecco, il protocollo di Nikolov ci dice che dipende dall'entità dello stress. Quindi vedete che questo è il protocollo originale, a seconda che lo stress sia più o meno importante cambia la dose di idrocortisone. Se lo stress è minore bastano 25 mg, se è più importante ce ne vogliono 50, se è più importante ancora ci vogliono 100 mg. E poi soprattutto le somministrazioni di idrocortisone vanno continuate finché la situazione di stress persiste. E anche se si deve interrompere l'assunzione di cortisone, perché ad esempio c'è una situazione di vomito per cui non è più possibile assumere il cortisone per bocca, il protocollo ci dice che bisogna prendere dell'idrocortisone al posto del cortisone solito. E se non possiamo prenderlo attraverso la bocca perché stiamo vomitando, allora si può fare ad esempio si possono fare delle iniezioni intramuscolo. Se invece si è in ospedale, l'idrocortisone viene somministrato attraverso la via endovenosa. Quindi, per riassumere, la terapia cronica con cortisone inibisce la produzione di cortisone in più endogeno quando c'è una situazione di stress elevato e quindi il protocollo di Nikolov ci dice tre cose. Somministrare dosi aggiuntive di cortisone in caso di condizioni di stress, non sospendere mai improvvisamente il cortisone ma farlo in modo graduale e poi ci dice che se dobbiamo sospendere l'assunzione di cortisone perché ad esempio abbiamo una situazione di vomito, allora dobbiamo prendere del cortisone aggiuntivo, sostitutivo, endovena o intramuscolo. Ecco, queste informazioni, l'altra grande intuizione è stata quella di non soltanto mettere insieme queste informazioni, ma anche
was
di
not to
renderle
put all this
facilmente fruibili.
information
E
together,
allora
but to make
è
it
stato
easily
fatto un
understood.
cartellino,
And
quello che
so
vedete a destra, in
what
che
you see
riassume il
on the
protocollo di
right-hand
Nikolov,
side,
e
this is a card
il
that
protocollo di
sums up
Nikolov è anche
the
stato
Nikolov
inserito
protocol,
in una
which was
emergency
also
card pubblicata
inserted
negli
in an
Stati Uniti.
emergency card that was
E
published
all'incirca
in
negli
the
stessi anni le linee
US.
guida di Lancet ci hanno detto che era importante introdurre l'emergency card per tutti i pazienti affetti da Duchenne, perché nonostante ci fossero state parecchie revisioni della letteratura e raccomandazioni per il trattamento in emergenza, non sempre queste informazioni erano note ai clinici e non sempre i clinici avevano esperienza nel trattare i pazienti con Duchenne. Quindi bisognava aiutarli, fare qualche cosa per aumentare il loro grado di conoscenza. In Inghilterra è stata prodotta un'emergency card simile a quella americana, in cui vedete che vengono dati gli alert sulle precauzioni da prendere per l'anestesia, sul protocollo di Nikolov, sull'insufficienza respiratoria, sull'insufficienza cardiaca, sulle fratture, in particolare le fratture di femore e il rischio di embolismo grassoso. Ecco, questo è un altro esempio di emergency card che è stata prodotta in Europa. Dopo aver preso visione di queste cose prodotte negli Stati Uniti e in Inghilterra, io e Filippo abbiamo pensato che era importante fare la stessa cosa anche in Italia. E poi abbiamo anche ritenuto importante aggiungere qualcosetta in più, cioè pensare che magari era difficile per la famiglia portarsi dietro tutte le informazioni cliniche relative al proprio figliuolo, e quindi poteva essere importante che queste informazioni fossero già contenute sempre nell'emergency card. E allora abbiamo deciso di fare un'emergency card costituita da due parti. Una parte generale molto simile a quella americana e inglese, in cui si dava al medico dell'emergenza le nozioni principali circa la gestione delle emergenze nei pazienti con Duchenne. E poi una personale, in cui ci fossero delle informazioni molto sintetiche relative al singolo paziente. Ovviamente questa emergency card personale doveva essere coperta da una password qualora fosse stata reperibile all'interno della rete. E adesso attualmente è possibile, passando dal sito di Parent Project, scaricare l'emergency card, quella generale. Infatti si entra, si scarica l'emergency card generale, che vedete è fatta di 2 pagine. C'è una prima parte in cui si spiegano quali sono le complicanze che possono insorgere nella storia naturale di un paziente affetto da Duchenne, e poi vedete le alterazioni respiratorie, quelle cardiache, i pericoli della terapia cortisonica cronica, le alterazioni della deglutizione. E poi c'è una seconda parte in cui si spiega come gestire, vedete in modo molto sintetico, le diverse condizioni, l'insufficienza respiratoria, cardiaca, quali sono i pericoli, le insidie delle fratture di femore, qual è il protocollo da seguire quando un paziente deve aggiungere del cortisone alla propria terapia, il protocollo di Nikolov, quali sono i problemi dell'anestesia correlata ai pazienti con Duchenne. E poi abbiamo pensato di fare 2 piccole implementazioni che non sono ancora disponibili oggi, ma lo saranno domani, nel senso che abbiamo pensato che fosse utile fare anche una versione in inglese dell'emergency card, in modo che i pazienti potessero portarsi questa versione qualora fossero in viaggio all'estero, e poi anche mettere assieme all'emergency card i riferimenti della letteratura, in modo che i clinici possano vedere che effettivamente queste informazioni vengono da una letteratura importante, e possano anche eventualmente scaricarsi i PDF di questi articoli, in modo da poter eventualmente approfondire, se ne hanno tempo e possibilità. Poi
Then there is a second component, which was a personalized or customized emergency card. In order to access the emergency card, you have to go through the register of a parent project. You have to fill in your username and your password. That is what will allow you, just with a few steps, the emergency card, the personal one. And you see highlighted the update day. Now, obviously, the clinical data have to be updated at least once every year. There is a reference center which follows the patient, and it says that the patient is diagnosed with a Duchenne diagnosis, and then they get the information for patients in the emergency ward, such as allergies, maybe to given substances, to given drugs, and what are the complications that have got to do with the Duchenne condition, or any other complication, maybe not having to do with the Duchenne condition, but that still belong to the clinical history of the patient. If the patient was previously hospitalized in previous years, whether he has any heart problems, respiratory problems, or any other problems, and then what are the treatments he's taking? Drugs, cortisone, ACE inhibitors, beta blockers, and also non-drug, because there may be non-invasive ventilation, the cough machine, the defibrillator, and all of the other things that could prove helpful for the patient in his everyday life. Then we selected not many exams, the abilities such as of the saturation, ejection fraction, and then 3 figures that give you the rapid idea of what is the baseline situation from the heart viewpoint and from the respiratory viewpoint. Then we also considered the possible treatment limits or limitations. Many patients do not want to be tracheostomized. And in here, it is also possible to read that the patient set some limits to the treatments he may receive. He doesn't want to be receiving any tracheostomy. For example, here we see 2 emergency cards, and I'm showing them as examples just to show you that whatever the severity of the condition of the patient, the emergency card is always very synthetic and concise. That's what's important. That's what matters. It needs to be read in just less than 5 minutes. This is a patient aged 18. He takes cortisone. He has a restrictive syndrome. He has a vital capacity which is slightly reduced. He's taking ACE inhibitors. He is doing thoracopulmonary expansions, and he's got an ejection fraction equal to 64%. This is a low-risk patient, should he ever end up in an emergency room. And you see that in less than 3 minutes, the physician can read what the situation is. But here, this is a much more complex case. In the same page, you get all of the needed information. This is a Duchenne age 42, allergic. He has a tracheostomy. He's been ventilated for more than 16 hours a day. He has severe dysphagia, swallowing problems, severe swallowing problems. He's nourished through a gastrostomy, so he has a parenteral nutrition. And he has a dilated cardiomyopathy. He is receiving heart drugs and heart treatments, but was never hospitalized for heart failure or breathing failure. So he's well compensated, and he never expressed any limitations to the treatments he would get. So this is a severely complex patient, and we can, thanks to the card, provide all of the needed information by the medical team in the emergency room. Then we know that this is a pen drive containing all of the information. It is going to be available not only on the internet, but it's also going to be available within the pen drive, I mean the information. And I would like to show what stage and how far we've gone with the drafting and filling of the emergency card. We now have completed 127 emergency cards, and I will show you the analysis of 123 of them, because in the last one, we added a few more. And the COVID pandemic didn't help us in improve our data input speed. Now here, you see patients are having 18 years on the average. They are non-ambulant. mostly, 79% of them are. And you see that the cortisone diffusion is very high amongst ambulant and non-ambulant patients. You see the green bar of cortisone is much more important than the violet or purple bar that is the one that do not take cortisone, as opposed to the ones who are taking and receiving cortisone. And we know how that important it is. Now, with respect to the risk factors, you see that the dilated myocardiopathy is not much widespread. Only a reduced percentage has that, 15%, and 76% of them nonetheless do take heart treatments that prevent the dilated cardiomyopathy, the hypokinetic one. And then you see that less than 50% of our patients, that is 46%, are receiving assisted breathing and assisted ventilation. Very few of them get enteral or parenteral nutrition. And this is also something which is important and significant, because severe dysphagia is not that much frequent and does not that frequently affect the Duchenne patients. As to respiratory assistance, you see that almost all of them are using the cough machine. This means that we have a home protocol which allows them allows the patients not to go to get assistance in hospital. 42 of the 57 patients that are assisted were also ventilated. The great majority were not invasively assisted. Only 3% had a tracheostomy. And only 8 of them expressed limitations to the treatments they would or may get. Tracheostomy is probably the main limitation that they all establish and set. They do not want to be tracheostomized, in other words. And when analyzing the two groups separately, we see first the ambulating patients. They are all less than 13 years old on the average. And you see that these boys do not have that many complications, so they are considered to be at a low risk of cardiorespiratory complications. None of them is ventilated. All of them have an effective cough. 2 of them only have a dilated myocardiopathy, and none of them has dysphagia. But here, if instead we switch to the category of the non-ambulant patients, we see that the age is different, as well as the risk component is different. We see that the cortisone group has an average age of 19 years. 31% are ventilated, 16% have a hypokinetic myocardiopathy. But if we consider patients not receiving any cortisone, they are older, because cortisone some 30 years ago was not that widespread. This is a patient situation showing an average age of 26 years of age. 39% has a significant hypokinetic cardiopathy, and 25% receive a parenteral nutrition. This is the group at risk of incurring in complications, so they need to be managed with special care, special attention. Then we checked with respect to the emergency card, what were the past hospitalizations of these patients, especially with the emergency unit or intensive care unit. And we saw that 20 hospitalizations were registered, 5 of them in the ICU, and almost all of them were due to acute respiratory failure. The other important thing and which should be stressed is that only one patient amongst the ones that are still ambulant was hospitalized, whilst all of the other cases were patients that were non-ambulant, no longer ambulant. Here, this is the geographic spread in Italy, across Italy. This is the situation in Italy. We have a good number of patients, even in the southern regions. There are some regions where we did work better. In other regions, we still have a long way to go. There are regions where no emergency card was filled or prepared, and that is where we have to focus. because we have to allow for the spread of the emergency card as much as we can. In order to do that, we thought that we could prepare a folder to hand out to reference centers, physicians, so as to allow for data that sometimes patients cannot retrieve or cannot find. So we would kindly ask to the referral centers to sign in and to fill in some information such as ejection fraction, for example, because patients sometimes don't have it. And not always the centers of reference never give this information to the patient, but they are really important because they tell us how much compromises the heart or the breathing function. And in an emergency situation, this information is of paramount importance. By way of a conclusion, let me say that this is what we should do, because the protocol of Nikolov could prove highly useful for emergency physicians. So we have to make efforts. We need more efforts to allow and to make it for more patients having the emergency card. And in order to make that come true, one possibility is the one of contacting or calling on to our own physiotherapists, Mara or Christina. You can see here their phone numbers. They will call you back. They will help you to create for your children an emergency card, and also the availability of a Nikolov protocol to be always with you. In the final words and thanks, I would like to pass the floor to Nicolo, and he is the co-author of this work, and Filippo probably would like to add a few more things. Now, Filippo, maybe I could advance your slides whenever you need. And it is going to be an honor to be supported by someone like you. I will be making miracles with the carousel and advancing the slides. Now, the slide that we don't see anymore, hopefully we will still see it in a few more moments and in future, was theoretically going to help us thank those who worked with us and helped us with the project. Okay, I will do once again the share screen or the screen share. Okay, that's going to be much better, but I could also sort of try and remember. Now, this is much better. The hard work that the slides took needs to be visible. Now here, let me fill the gap. Let me say that Fabrizio was the maker, #1 maker of this very important project, which is only now in moving its first steps. It recently take off, and this is important because Fabrizio, as we know, is a non-stop working person, which is what rejoices us. But the fact that he is the one that realized this project, and as you probably know, and you've been knowing me for 25 years, I do adore talking and speaking, but whomever does the hard work is always preferred. I just would rather have them do it, because obviously lazy people can find a way to do the best things with not much work. And this is the reason why I was leaning on Fabrizio, because he's always very much helpful. Now, here are those who were involved. Christina, you've met her during this conference. She's a physical therapist, and she's going to be supporting all of you in all of the issues. Then she's been supported by Mara. She's a rather new one, but anyway, she is giving an incredible impetus to the emergency card compilation. And then there are the 3 other persons that are in charge of science and scientific approaches: Gloria Antonini, Fernanda De Angelis, and Ilaria Zito, who, as I said, is in charge of the register of parent project containing the source of information to be copied into the emergency card, because this is what will help the patients to share their own data with the physicians. That is always a very important and key factor. So my opportunity right now is the one of thanking all of these people for helping us, for their great endeavors and collaboration. And then let me say that today, the presentation was made possible thanks to the grant provided by the Nikolov family. And here you see Barbara, the wife of Brian, then Brian, Justin, the youngest brother of Philip James. Justin also has the Duchenne dystrophy, but a more benevolent, a less severe situation. I think that he's more than 35 now. Am I right, Pat? Then thanks to the Nikolov family
exactly right.
for having funded this spread or diffusion PJ protocol. And this is my last slide, a beautiful one. And Brian is here smiling together with his son. And he says, no, there isn't a day that goes by where I'm not thinking about the PJ protocol or I do something for it. I know that it's going to prove helpful. PJ is eternal thanks to this protocol and I think that this is the sentence of Brian Nikolov that encompasses our secrets. All of us have a secret, and this is our secret. And because what we do is important for our children, but also for all of the other people that share this predicament. So many thanks to the Nikolov family, to Brian, and this will generate incredible results. So many thanks to all of you. And now we will allow for a few more questions. Here we see Brian saying thanks, but we are the ones who should thank him and his entire family. So many thanks, mutual thanks, I would say. Now, Adele D'Amico takes the floor. And I think that the emergency card is very important. Should we fill in the info and maybe the reference physician should do that, or should we do it ourselves? I believe that the physician should do it, but we are available to do that for all of our patients. This is something that we will do whenever we take stock of the situation. We will show our beautiful emergency cards. Christina will give you the updates as soon as we've read the new incoming questions. And I don't know whether Fabrizio, let's go back to the previous question. Well, Fabrizio is saying that he is in agreement with Adele. The emergency card should be compiled by the reference physician. So it's the physician who should fill in all of the relevant information and data. And maybe because of the COVID pandemic, it was difficult to achieve that because we were all of us very busy in defending and protecting ourselves from COVID. So this is why we tried to recover the documents from different centers. And out of the documents, we could glean the information that we would need to compile the cards. And as I said before, that was not an easy work, not always. And some patients, unfortunately, did not always keep a report of the visits they had in the different centers, or the reports were not containing all the details and the data, such as ejection fraction and the vital capacity. But in order to help the centers, because we do realize that the work is a huge work and the time is never enough, we produced this tiny sheet that I showed you before, which should be given by the patient to the treating reference center physician. And this is what allows, in just a few seconds, to feed in and to enter the missing data. We've seen that the ongoing treatment can be reconstructed thanks to an interview. What cannot be reconstructed and brought back are the data and the numerical data or the tests. But each center, whenever available, could step in and help us. That would be ideal. We would like very much have the emergency card prepared by the reference and or referral centers. That would make our life easier. and the card is going to be more accurate at the same time. And I think that in the first 123 emergency cards
were filled out very accurately.
Data were fed
because
very accurately. We wrote down,
reported all of the data,
fed in only certain
we
data.
collected
I mean, the ones that we were sure of. And the effort on the side of Parent Project was very important.
Made a huge effort
so as to recover
to retrieve all that information from every individual patient.
So the help coming from the centers would prove to be very important.
È una persona che ha sempre collaborato con noi e siamo ben felici di continuare a farlo. Abbiamo qui qualche altra domanda. C'è una domanda che
There's a question. How can I obtain my personal emergency card if I am not part of the patient registry of Parent Project, and how can I sign up? I don't think the two things are linked. Probably privacy and the disclosure module or form is something you need to fill out for sure. But the advice I can give you is to contact our counseling center using the toll-free number 843-333. Do you remember that? I don't remember it by heart. 943-333. Well, never mind. We'll get it to you. I guess I'm aging because the toll-free number is something I've always known. You can also contact the scientific department on WhatsApp at 342-3289199. And Ilaria Zito will answer directly. And she is the one who directly manages the patient registry. Through her, you will be able to get a lot of information regarding how everything works. As Fabrizio Racca pointed out, we have all of that information on our site. You can also fill out the emergency card without being registered, but as Fabrizio said, because we also want to include the clinical history and having data is essential for the management of our patients. The two activities are interlinked. And the emergency card is a vehicle to have people find out about the patient registry. So please contact Ilaria. It will be easy to get your emergency card. There are steroid regimes. This is a question that do not advise the protocol. For example, I take cortisone 20 years and 10 days I don't. So, Fabrizio, can you help us to answer this question? I will try. As to the information, or based on the information I have, a regime of this kind, I don't think, does not inhibit the axis and it doesn't depress the adrenal gland. But this is a very special case that you mentioned. So I think that it would be important in such cases to consult with your endocrinologist. I have to say that an additional dose never creates major problems. So in case of doubt, it's better to take the additional dose rather than not taking it at all. But 10 days with a drug and 20 without, well, I don't know. It could be enough time. But I don't know. I think it would be best to contact an endocrinologist and get a definitive answer from them. Okay, thank you, Fabrizio. There was another question that I think we skipped. I live away from my resource clinical facility. What should I do? In case of an emergency, should I go to the nearby emergency room? My suggestion is yes, take your card with you, take the emergency card with you. But in this case, I think we will ask Professor Racca for his advice. I agree with your answer. I think we're perfectly in sync. It's really important to consider if a patient has respiratory failure in peacetime, so to speak, the young patient should have been trained to a protocol. He must have learned the protocol, and same with the parents. They must know about that. I'm not talking about the Nikolov protocol, but the John Bach protocol. Know what to do when you're affected by acute respiratory failure, because even if you go to the emergency room, if it's a local small place, the doctors you find there may not know what's going on. So the first thing is to have a very clear idea as to what your vital capacity is. And that's why this is a finding that every patient needs to have. This is absolutely crucial. If vital capacity is lower than 50%, then training must begin in time of peace, as I like to say, so that you're ready in wartime. So that means you need to start thinking about the need for ventilation. You need to start having maneuvers. Maybe you don't need a cough machine yet. Maybe an abdominal push will be enough, but something needs to be done. That's the first step. The second step would be to have the emergency card and the Nikolov protocol with you. So if you go to an emergency room and you encounter caregivers who are not so experienced, it'll be okay because the relatives know how to deal with cough. The protocols are shown to the ER practitioners, and then the practitioners in the ER will know what to do on the basis of all that. Once the patient is safe, if there are some severe failure issues, the patient will be transferred to another more experienced hospital. But if you are very far away from major hospitals, it's crucial to go to the nearest emergency room, because the practitioners there, I'm sure, will be able to give a helping hand. Maybe they won't be able to do everything, but they will be able to save the patient and possibly transfer them to a different facility, more experienced. But the more we help the practitioners, the better. So training before the acute situation sets in, an emergency card to be carried along with a copy of the protocol, the Nikolov protocol. That would be my advice. Perfect. Thank you, Fabrizio. I think that we just need to add something, which is a little bit the philosophy of Parent Project. The first thing I learned is to stay away from hospitals and ERs, because that's the best thing to do, as Pat taught me. But when you've done all that you can to stay away, and unfortunately the situation is such that we need to go to these facilities, then what Fabrizio just said is what we should do. Know the fundamental protocols to be able to manage all of these emergency situations, and then get help from doctors and help the doctors ourselves. We have another question from Deb Robbins, who's an old acquaintance of ours. Deb Robbins has taken our association all the way to Australia, and we've worked for many, many years with her. Deborah says, we have personalized, tailored information in a foldable pamphlet that we use, but we also have space for some detail, like a rhabdomyolysis warning. The Parent Project app, I think she refers to the Australian and the American one. The PPMD app on our phones has a storage space for all explanations. A data card The larger data card you've designed seems to combine both longer explanations and personalized information. Congratulations, she says. So she doesn't really have a question. She's congratulating us, saying basically that we were able to combine both initiatives that we had done in the past. Thank you, Deb. We accept your congratulations. It's always an honor to hear from you who are on the other side of the world. From Daniela Argili, we have a question. Might it be useful to make contact with the hospitals of the cities in which patients live that are often different from reference medical centers to circulate the Nikolov protocol and the emergency card? Well, actually, what Brian Nikolov said between the lines in his story, he said basically make contact with all possible centers and facilities and make sure that in their guidelines they include a reference to the Nikolov protocols. Through which channels? Well, ER doctors, ER practitioners, general practitioners, other hospital doctors. How can we inform doctors and hospitals? She asks. And I reply, well, we have to be aware of the information and disseminate it. So thank you, Daniela, for that question. And thank you for bringing that up. Fabrizio, would you like to say anything in addition to what we've already said? Yes, two things. The first thing is that in the site of Parent Project, you should perhaps add the bibliography related to the emergency card. It's really going to be important because ER practitioners will be able to see that our statements are founded and they are backed up by the literature, number one. Number two, whenever possible, according to my experience, it's really useful to have phone contact between the expert doctor with local doctors. I've often been able to talk with them using the patient's phone, for example. And I have always found the local physicians in the ER practitioners to be very ready and willing to help, even though they did not know me. They always listened to what I had to say, and we always were together very fruitfully. If possible, obviously, it's not always possible. But if it is possible, it's an extra asset to best or better manage our patients in emergency situations. We promise to answer all of these questions as soon as this session is over, but I'd like to take advantage of the very few minutes that are left to introduce something. Now Pat's with us, so maybe she has something to add. We'd be happy to hear her suggestions, but anyway, we'd like to talk to you about what's in store for the dissemination of the Nikolov protocol. We are going to show you a slide to tell you what we intend to do to give further visibility to the protocol. First of all, we're completing the revision of the translation of the Nikolov protocol. And we would very much like to thank Dr. Luca Bello, who helped us in reviewing some parts. This will be created graphically with all the materials. And together, with the contribution of our families, we will contact all clinical centers, even those that are not referenced clinical centers, to disseminate the protocol. We will produce a large quantity of the protocol so that it may be disseminated throughout the country in Italian, so that pediatricians can get to know it, ER practitioners, general practitioners, and the families, because they are keys. We will distribute our fantastic pen drive that looks like an ID card. And here you will find all the patient data. We will send it to all families, even those that do not yet have an emergency card, because as soon as they do have it, they'll be able to keep it with them. So this will promote, of course, the emergency card. This came straight from the printing press yesterday, and we are expecting the pamphlet that Fabrizio Racca explained and that you'll find on our website. We will continue to disseminate the protocol, and we will make sure that the whole community is aware of the protocol and of the fact that we created this card. So for this year, we'll be very busy because we have many patients, many hundreds of patients in the registry, and our goal is to reach out to each one of them. So thank you once again to the Nikolov family. I'd like to thank also Fabrizio Racca for his valuable and constant collaboration. I'm sorry, I called him on Ferragosto in the middle of August. Fabrizio, we called him, and because I had a patient who was in a terribly stressful emergency situation, but he answered right away, in spite of the fact that it was the middle of August. Professor Pat, my teacher, I continue to learn from you. And every time I see you, have something new to teach me. So thank you, because as long as we learn, we never grow old. So thank you, Pat. And we never grow tired of learning from you, from Pat, from Fabrizio Racca, and from Professor Emma Pedraro, who you may not see, but she's there because the next session is about to begin. There will be a changing of the guard here in our spaceship, and we will leave the helm to Dr. Laurenzana, who is connected from home. He's a member of the steering committee of Parent Project. And as soon as we are able to switch to Fernanda De Angelis, we will leave the spaceship momentarily anyway. And we will ask Fernanda to take over the chairmanship. Thank you. The next session will be about clinical trials on BMD. Stay with us, please, because after that, there's another session at 4:30 p.m. And especially, please stay until the very end, because we want all to be with us. Thank you very much for this session, and we'll begin session number 7 on clinical trials in BMD. Fernanda, you have the floor.
Eccoci qua di nuovo.
So here we are, back to you. Hi, everyone, again, welcome. Welcome to the speakers, and most of all, welcome to Gerardo. This is a session dedicated to clinical studies of the muscular Becker dystrophy. I am the moderator, and I'm so happy of being a moderator together with Gerardo Laurenzana. He is one of the members of our steering board, but also a very active member, together with many more. And when we talked with Gerardo to see how to set up the session and design it, we talked and we discussed about many things at length. And we also said how much these spaces devoted to Becker disease were catching the attention in recent years, webinars, meetings after many conferences, last year's session, this year conference, and how they are important for the community. But in order to explain the reasons of all this, I believe that I should pass the floor to Gerardo. And please do have the floor, Gerardo. Many thanks, Fernanda. I'm so very happy myself of being here with you and of sharing and experiencing all this. For many times, the Becker community was sort of set on hold and placed on hold because of clinical studies and research, where the possibility of assessing the strategies that could also fit for the Becker ones was depending on the studies of the Duchenne patients, while waiting to better understand our condition, its characteristics. And although in part it is overlapping with the Duchenne one, it's not really the same thing. Ours was not a silent wait anyway. We are in the parent project group, and we started taking steps forward. We had a first webinar, a first meeting focusing on the Becker, which is what allowed us to better understand and at the same time to focus on our needs and to make our needs be heard. Our voice was heard. After that, people were listening to us. Today, we have the guidelines as to the management of the Becker condition for patients' families. That's of paramount importance. That document was made last year thanks to some clinicians. One of them is here with us today. And these people made available their own experience to us and their own skills so as to help families, patients to manage in a better way this condition and to approach it in a better way. At long last, after a few years, also clinical trials provided us with the possibility of contributing to the studies, because thanks to our own participation and the progression of research, the progress of research. I am proud to say that this was a change that was very much wanted, not just by us, but together many more people who contributed it to make it come true. So with these words, I would like to launch the session, and I would now straightforwardly introduce the first speaker of this session, Sara Cazzaniga, a manager for research and development of Italfarmaco, the clinical developments. She will be sharing with us the results of a clinical study with the Givinostat in the Becker Muscular Dystrophy. This was a study that was coming to an end last year, and that was involving a broad, large group of patients. It took place mostly in Italy with the Teaching Hospital of Milano, the Polyclinic of Milano. And now let's pass the floor to Dr. Cazzaniga, Sara Cazzaniga. Okay, let me share my screen in the first place. Just be patient and bear with me. It takes me a little bit. Here I am. Many thanks. Thanks to Parent Project for inviting us to share with you our results, the Givinostat in the Becker. This is the disclaimer. What I want to stress is that Givinostat hasn't yet been approved. It's not on the market yet in no country, not even in Italy. And most of all, that this presentation is only aimed at scientific purposes. This is my agenda. So Givinostat is an inhibitor of the inositol acetylase. But what has it got to do with the dystrophy in general? You probably know that dystrophy has a fundamental role with muscles, and it has two main roles. One is the one of protecting, from a mechanical point of view, muscle fibers, but also a dynamic protection with respect to chromatin, which is the reason why the HDHI enzymes, especially the HDHC number 2 enzyme, is protected. Now, we know how important dystrophin is with the Becker and the Duchenne, which, when lost, increases the damage suffered by muscle fibers. And there is an increase in HDAC2, which leads to the expression that's altered of the genes important for the muscular regeneration. And all this translates into a muscular damage with a further compromised repairing system. And the muscle is being replaced by fat tissue and fibrotic tissue. So let's see where Givinostat comes handy. It will not restore the dystrophy, but it could counter the effects of the lack of dystrophin. As Gerardo said, there are some similarities between the Duchenne and the Becker. We had some positive results with the phase 2 of the Duchenne, and the company, thanks to some economic support provided by the European community and by the Lombardy region, decided to use Givinostat in a study, phase 2 study in Becker patients, adult patients aged between 18 and 65, ambulant patients. They could talk up to 450 meters. This is the design of the study. The design was a double-blind plus placebo controlled study. Patients were undergoing a muscle biopsy and a magnetic resonance of the muscle at the beginning and after 12 months of treatment, and they were randomized 2-1. And every 3 months, they underwent tests, functional tests and strength tests, and also the safety ones. At the bottom, you see that we randomized some 50 patients, and that the 2 clinical centers involved, the one in Milan and the one in Leiden, Professor Mix and Professor Comi, screened 250 patients so as to randomize at least 50 of them. Then we had 50 patients treated with Givinostat, 17 with the placebo, and some of them did come to the end of the study and the treatment. 2 patients, unfortunately, because of COVID restrictions, were coming from abroad, and they were managed and handled by the Milan Center. And they unfortunately could not go on with the study because of the COVID restrictions. They couldn't travel anymore. So those 2 patients had to discontinue the treatment because of adverse events. One because of a low count of platelets, and the other because of increase of triglycerides, which disappeared when they discontinued the drug. The placebo patients completed the study. 1 patient in the placebo group discontinued the treatment because of triglycerides increase, which then went back to normal at the end of the study. I will now show you the characteristics at baselines. On the left-hand side of the slide, the mean age of the components and the diagnosis time is the one of the reception of the genetic test. On the right-hand side, we see the baseline parameters. Total fibrosis in percentage terms, that was the primary parameter that we wanted to check. And we talk about histology, we talk about the results, and we also see magnetic resonance and test results. Let's take a look at total fibrosis, which is unbalanced at baseline. But as to the correlations made with the baseline information, we found no correlation in between time, age, and diagnosis for dysfunctional parameters and physiological ones and magnetic resonance. But we highlighted a correlation which is very important in between histology and magnetic resonance parameters and the strength parameters, which is what has been recently published. Now, let's take a look at the results of the study. We start with the primary endpoint, which was the percentage of fibrosis in percentage terms after 12 months of treatment. As you can see in the slide on the left-hand side, we see the percentage of fibrosis at baseline in the placebo group, which is pink, and the Givinostat patients is in the green column. We see a high percentage, and we see how unbalanced it is amongst the 2 groups. This is a very important thing to be borne in mind. On the right-hand side of the slide, we see the changes at baseline. And as you can see, there was no significant change in both groups, and it seems to be no difference in between the two groups. The primary endpoint means that the primary endpoint was not achieved. Now, secondary endpoint. We had magnetic resonance endpoints. The morphologic aspect of the muscle is of paramount importance. And here we have two boxes. On the left-hand side, we see that we have highlighted the percentage of fat in the thigh muscle. On the right-hand side, instead, in the quadriceps. As usual, we have the two bars. The green one is the Givinostat one, which is showing the percentage at the baseline and then the changes after 12 months. At baseline, we see that the two groups are similar. And then after 12 months, we see an increase in the percentage of fat in patients receiving placebo, which is much superior than the ones treated with Givinostat. And the difference between the two groups is statistically significant. You can see that the increase of fat in the placebo group is indicative of disease progression. We not only looked at the percentage of fat that was assessed with the magnetic resonance Dixon technique, and here we see also the contractile area of the thigh and of the quadriceps. You can see that what we noticed was that after some 12 months in treatment, the placebo group, the contractile area was reduced, in the Givinostat stayed stable. And here the difference between the two groups was also statistically significant and favorable to Givinostat. And as we also said before, the evolution of the contractile area in the placebo group is indicative of muscular atrophy. Now, the results of the strength functional tests that were assessed were the walking test, the 4-step test, the 10 meters, TTR, and all of the tests showed no change in the course of time in the Givinostat and placebo groups. And let me just say that Professor Siciliano yesterday showed a presentation of Becker Italian patients where after 12 months there were no changes in functional terms. Same result was also highlighted in terms of strength tests. No changes in both groups, placebo and Givinostat, and there were no differences between the two groups. And now let's talk of the safety aspect. As we know, this is a phase 2 study. We had no serious adverse events, and the most frequent ones were the ones known with Givinostat, such as diarrhea, meaning that there is a problem at the gastrointestinal level. There is the platelets are affected, and we saw that 70 milligrams twice daily was the initial dose, and going down to 50 milligrams twice daily was what reduced the adverse events. All of the other parameters, safety parameters, were also assessed, especially the heart ones, the respiratory ones, and we did not see or observe any problem. Now, what are our own conclusions? What are the next steps to be taken? Let's get started from the histology. We saw high variability, not only between the two groups, but also inside the same group. This heterogeneity is well known in the Becker group, and we also noticed that in the histology. We saw the imbalance in the basal groups, and there were no changes in the 12 months, as well as in the placebo group. So this is what probably contributed to providing a negative result for the primary endpoint. As to the magnetic resonance, we had good results. We think that this is what allows us to see that Givinostat can fight the Becker dystrophy, muscular dystrophy, preventing the formation of fat and muscular atrophy. As far as the test of strength, 12 months are not sufficient, and we noticed that the progression of the disease in the Becker is much slower than the Duchenne one. So 12 months probably is not appropriate in order to prove the efficacy of the drug. Last but not least, we also have a good safety profile with Givinostat with the Becker patients, which is what makes us expect good evolutions in the future. Next steps. These results appear to be very encouraging. We are now looking at the collected data. There are so many. We also collected biomarkers, and we are still going on with our own research. The researchers are analyzing the results in order to assess whether it is possible to identify populations such as a more precise target population. And we also envisage some meetings with regulatory authorities in the US, but also in Europe, so as to design together with them an adequate evolution for Becker patients taking Givinostat. Here are my thanks in the first place to the Becker patients, and they made themselves available even during the pandemic. And we would like to thank the domiciliary nursing staff that went to check patients at home and the many companies that helped us. And now here you can see my email address. Should you ever want to get more precise and accurate information, please write and call on me. Thank you.
Thank you very much.
Many thanks, Doctor.
And
now I would like to welcome Professor Pecoraro. She teaches neurology with the Department of Neurosciences at the University of Padua, and she's also director.
I'm sorry, let me just. I was saying, she teaches at the Department of Neuroscience at the University of Padua, and Professor Pecoraro is among the main clinicians of reference for the DMD and BMD community in Italy, and she's going to talk to us today about a new clinical trial that is about to start in our country. We cannot but thank her once again for the great work done, which was completed partly thanks to the contribution of many other clinicians. And I'm talking about the guidelines for the clinical management of BMD. Let's now hear the details of this new trial that will look at vamorolone versus placebo in BMD. Thank you and good afternoon, everyone. In the next few minutes, I'd like to talk to you about this phase 2 trial in BMD. For over 40 years, we know that glucocorticoids are effective in BMD. They are capable of slowing down the disease. They improve muscular force. They make patients quicker in walking and climbing stairs and getting up, and they delay the loss of ambulation. These are patients treated with cortisone and those untreated. Those who are treated walk 18 to 20 months more. The beneficial effects are also in the upper limbs as well as in the respiratory and cardiac function. So glucocorticoids are a part of the standard of care in BMD. The mechanisms of action are many, but they certainly have a role as anti-inflammatory agents. However, unfortunately, alongside the significant positive effects, there are equally significant side effects affecting quite a large number of patients: osteopenia, osteoporosis, weight gain, the face changes. Sometimes there are behavioral issues, and sometimes at the beginning of treatment, irritability. They can induce cataract, and in some patients, we also see the onset of gastritis, diabetes, and hypertension. Thankfully, we're capable of treating these side effects, but that they do make treatment with glucocorticoids quite problematic. Ideally, if there were a molecule that would do away with side effects, then this molecule would definitely be one of choice. Well, This type of molecule is called a dissociated steroid, and vamorolone is one of them, and has proven to be efficacious in BMD. It's capable of maintaining the beneficial effects of cortisone, but it is able to do away with or reduce side effects. The data will be presented shortly. What I'd like to point out is that DMD and BMD are due to mutations in the same gene, which is translated into an altered synthesis of dystrophin. In BMD, this is what it looks like. However, the pathogenic mechanisms unleashed by the dystrophin deficit are similar in both conditions. And so a rationale is to look at the efficacy of vamorolone in BMD. This is why we designed this pilot trial, phase 2, randomized and double-blind, which looks at the safety, tolerability, and efficacy of vamorolone at 500 milligrams per day orally versus placebo for 24 weeks. The pilot trial will enroll 39 subjects with BMD with an age between 18 and 65, or who have not taken glucocorticoids for at least 3 months. Patients will be randomized 2 to 1. Every 2 patients vamorolone, and 1 will be assigned to placebo, and they will be treated for 24 weeks. This is the design of the trial. There's a pre-screening time in which patients will be evaluated. On day 1, vamorolone will be administered, and that'll continue for 24 weeks. At the end of the 24 weeks, if there is a possibility, patients will be enrolled in an extended access program. Otherwise, they will be monitored for another 4 weeks to reduce the dose of cortisone, because as was rightly said, patients who are chronically treated with cortisone cannot abruptly discontinue cortisone because of the risk of adrenal failure. What are the main inclusion criteria? Well, males, obviously, with a clinical phenotype consistent with the BMD, that have a deletion in one or multiple exons of the DMD gene, and an abnormal dystrophin in the skeletal muscle. The age is between 18 and 65, 3 months without glucocorticoids, Alongside these criteria, patients have to be capable of walking and walking 10 meters in less than 30 seconds. And at the NSAA, they have to have a score of 32. The main goal, since this is a phase 2 trial, is to evaluate the security and the tolerability of the agent. So for all 24 months, we will be registering adverse events and serious adverse events. We will also monitor all the parameters that can be altered by cortisone. So height, weight, arterial blood pressure, liver function, biomarkers of bone metabolism, glycemia, CK, which could be reduced during treatment with vamorolone, and lipid profile. Secondary goals are shown here: the evaluation of pharmacokinetics and pharmacodynamics in BMD. Pharmacokinetics essentially studies the processes of the body on the agent. So a sample will be taken on day 1, and then 1 and 2 and 3 hours after the administration of vamorolone. Instead, pharmacodynamics looks at the effects of the drug on the body. So a blood sample will be taken prior to the administration of vamorolone for baseline, and then at day 1 and at weeks 12 and 24, we will try to see whether vamorolone has determined adverse effects on metabolism, especially resistance to insulin and and also glycate hemoglobin, which looks at the balance over 3 months, and then the levels of insulin. We will also be looking at biomarkers associated with bone metabolism. Osteocalcin is a protein of the bone matrix, and so it increases in the blood whenever there is a greater turnover. We'll also be looking at efficacy biomarkers. These biomarkers were identified in these two proteins, and because they're inflammatory biomarkers, we hope that they are low. And finally, we'll be looking at cortisol, because we want to see how it acts in the adrenal glands, which produce cortisol in our body physiologically. Exploratory goals are the efficacy of vamorolone, and to measure that, we are going to be looking at the North Star scale and the walking time and running time of 10 meters. Also, the patient reception after taking the drug will be monitored. These findings are increasingly important in the regulatory aspects that will lead to the approval of the drug. In other words, patients will have to assess how vamorolone affected their levels of fatigue, their ability to move and to walk. The centers involved are the University of Pittsburgh. Paula Clemens coordinates the trial, and the University of Padua, and then the hospital university. I will be working on that together with Dr. Luca Bello. We would like to enroll the first patient in the first 4 months of 2022. It's going to be a patient from the US. I can anticipate that for regulatory reasons. And then the last patient will be enrolled in the first 4 months of 2024. What do we expect from the study? Well, we hope to be able to show that vamorolone is safe and tolerated also in BMD, that it has a pharmacokinetic profile similar to that of DMD, and hopefully we'll be able to show that the inflammatory biomarkers identified as candidate biomarkers in DMD are confirmed in BMD. By way of conclusion, Becker muscular dystrophy right now has no therapy, although it should be stressed that the main complications are therapeutic targets of great efficacy, but there is no single drug that can actually get to the root cause of the pathogenetic mechanisms. And BMD has always been considered less serious than DMD, but it certainly has unmet clinical requirements. To date, the side effects of glucocorticoids have discouraged its use in BMD. Treatment with vamorolone, which was proven to be as efficacious, safe, and well tolerated in DMD, will also apply to BMD, hopefully. And I'd like to take this opportunity to thank Paula Clemens in Pittsburgh, who coordinates this trial, the funding entities, Reveragen, the FDA, the Foundation to Eradicate Duchenne, and of course, Kaufman, who's always guided and supported the developments of this study. So, thank you so much, Professor Pegoraro. I'm happy to show you a paper version of these guidelines on the clinical management of BMD. Families will be receiving it shortly. And once again, as Gerardo did, I'd like to thank Professor Pegoraro and all those who contributed to this immense piece of work, which is so crucial. And now I'd like to give the floor to John Donovan from Twice, who will speak to us about the clinical development of a molecule called ADG 5506, which is being used in BMD. So I'd like to thank Joanne Donovan, who's in the US. Good morning. I'm sure it's morning where you are. And please go ahead with your presentation. Thank you.
Buongiorno. Grazie. I am very happy to speak to you today about EDGE 5506, which is a novel small molecule that aims to protect dystrophic muscle, both in Becker muscular dystrophy as well as in Duchenne muscular dystrophy. We are a public company, so this is our disclaimer. I'll be talking about things that happen in the future, and I am an employee. And of course, EDGE 5506 is investigational and not yet approved in any territory. So basically at EDGEWISE, patients are at the core of everything we do. Our goal is to improve the lives of patients and families that are suffering from rare muscle disorders and to develop innovative therapies, new therapies for muscular dystrophy that can be used alone or in combination and are convenient to administer. These are oral therapies. So we're focused right now on Becker and Duchenne muscular dystrophies, and we're in the process of starting phase 2 studies. So the approach is a bit different than what you've heard about over the past day and a half. And in the past, we know that some muscle fibers are more susceptible to damage because of either the complete absence of dystrophin in Duchenne or a partial lack of dystrophin in Becker. We've developed an investigational therapy that's designed to protect these susceptible muscle fibers from damage. And we've seen that in diseased animal models, EDG 5506 protected these susceptible muscle fibers and prevented longer-term development of damage. Now, just to step back, what we're trying to do here is to protect muscles from the stress of contraction. The muscles contract when myosin, two proteins, myosin and actin, work together. What dystrophin does is it prevents injury. And dystrophin is this small yellow part here, and it links the myosin and actin to the structure of the membrane of the muscle and to other cells. And by linking to other muscle fibers, it distributes stress over the muscle. It doesn't work by actually powering the muscle. So when muscles without functional dystrophin are stressed or they work, damage happens because they're unable to distribute the stress across the muscles. And that leads to replacement with fat and fibrosis, and in the end, loss of muscle function. If we can modulate myosin with a compound like EDG 5506, we can stabilize even in the absence or relative decrease in the amount of dystrophin. So this is a new strategy. It's one that others have not worked on to decrease the effect of mechanical stress and to protect skeletal muscle, even if dystrophin is lacking. And so what happens here, and this will, I'm just making sure it's playing. So these are muscles from a mouse. They're basically finger muscles from a mouse. And they are from an MDX animal. You've heard about MDX as a good model for Duchenne. And they are contracting. The ones on the left are contracting without anything added, and the ones on the right have EDG 5506 added. And what you can see start to happen in the muscles on the left is that there starts to be these little dots, and that's actually proteins that are clumping together. And the muscle, there are some of the muscle fibers are starting to break up. So you can actually see the damage that's happening with contraction. On the right, with EDG 5506, you're not seeing those changes. And that's reflected in animal studies where we've looked over a year and seen both decreases in biomarkers, decreases in fibrosis, and actually improvements in function in these animals. Now, of course, the goal is to move to people. And what we know is that injured muscles, both in animals as well as in the clinic, the injured muscles release muscle proteins, and we use those as biomarkers for muscle injury. Now, you know that you're very familiar with creatine kinase, CK, and there are other biomarkers that are very high in Duchenne and in Becker muscular dystrophy. These include myoglobin, fast troponin, which is a specific protein for the kind of the type of muscle fibers that we are protecting, and many other muscle proteins. And these enter the bloodstream, and we can measure them both in animals and in people. So we've started studies. We've completed a phase 1 study in humans. And first, we looked in unaffected adults. And what we found in terms of understanding side effects is that when we dosed EDG 5506 for 2 weeks, it was well tolerated. The most common side effects were dizziness and sleepiness. We also were able to figure out how should we dose it in the real world. And we found that it's able to be dosed as a pill, it's absorbed well, and it can be taken once a day with or without food. So that's convenient for patients. And a really important question in developing drugs for dystrophinopathies is, does it get to the muscle? Does it get to where it's supposed to be? And we found with muscle biopsies, both in the unaffected adults as well as those with Becker, is that it's very highly concentrated in the muscle compared to the blood. And that tells us that it's getting to where it needs to be to help protect the muscle, basically. So we know it's getting there at the concentrations that we need. Now, we looked also at 7 patients, 7 adults with Becker who were wonderful enough to come to a phase unit and stay basically for 3 weeks and get poked and have blood drawn and be very carefully monitored. And we saw that the safety was similar to what we had seen in the unaffected adults. And what we were very encouraged to see is that there was a rapid decrease in these biomarkers of muscle damage in those with Becker muscular dystrophy that were treated for 2 weeks with EDG 5506. So when people are in a unit like this and they're not able to walk around the way they usually are, the CK does tend to go down. You know that it bumps up and down on almost a daily basis. I think that Dr. Flanagan said yesterday that you can see these changes. So people are a little bit more, are resting a bit more. And so they did go down, those on placebo. But the ones on EDG 5506 went down almost to essentially the levels of unaffected adults. And this was statistically significant. We also looked at fast troponin, which is very specific for the type of muscle fibers that EDG 5506 affects. And we found that there was a little bit of change in placebo, not significant, but the levels went down with EDG 5506 just about to normal levels. So even in a small number of patients, we're seeing very promising biomarkers in over even 2 weeks of treatment. So what we're doing longer term is thinking ahead. We are looking at EDG 5506 to preserve and potentially improve function in Becker and Duchenne patients without any mutation by preventing damage to muscle and allowing regeneration. It has the potential to be used in combination with other therapeutic approaches for dystrophinopathies that are in development. And it's really designed to stop the damage at the very first step, where the mechanical stress is causing damage to the muscle. And this is a new mechanism of action that we are developing. We have several clinical trials that are planned. We have an ongoing study, an open label study, to include the participants with Becker who were in the phase 1 study, as well as several others. This will allow us to look longer term at safety and pharmacokinetics. We're also planning a study in adolescents and adults with Becker to start the first half of this year. That's planned in the US and in several sites in Europe. I'm sorry to say that it is not planned to be in Italy at this point. We are also planning an initial study in boys with Duchenne the second half of this year, and that's in the planning stages, so I can't tell you very much about that at this point. But we are ultimately certainly planning a global program for Duchenne for a phase 3 study. So I'd like to thank you very much, thank the participants in the study to date, and here's our contact information should you wish to get in touch with us and ask more questions. Grazie.
Allora, grazie mille, Joan. Grazie.
Thank you, John, and many thanks to all of the other speakers. Gerardo, please forgive me, I stole your microphone. This is the beauty of going live. You should have been speaking instead of me. Okay, back to me. Thank you to all of the speakers that participated today on behalf of all of us. And the biggest thank, the most profound thank comes from our boys, from Antonio, Fabio, Alessandro, Francesco, Michele, many more. They are the ones who thank you. As a parent and as many more parents, I would like to thank you. We are on the right track, that the results will soon be cropped. And I hope you have heard our words and that they touch your hearts. You should not just think, and we should not just think in terms of those who have 60 years old, who are 60 years old and who lived a perfect life with her. There are so many other people who suffer more severe conditions. So they are the ones we should target. Deepest thanks from our heart, from all of us. And once again, back to the control room, to Fernanda, Antonio, for possible Q&A. And once again, many thanks. 1,000 thanks to you, Gerardo. And let me say, and let me remind to all of those who have logged in, there are so many of them, that on Thursday there was a beautiful parallel session having to do with the Becker dystrophy. Many boys partook that and logged in during that session, which was recorded. It will be made available soon, together with the rest of the whole conference. So please, please, I invite all of you, if you couldn't log in, please try and do so. That was a wonderful moment. Access that session, that parallel session. The boys were sharing so many beautiful things. So please, please come in. And now, as you saw, someone else is here with me. She is sitting next to me in the control room of the spaceship. Antonella, Gloria, Zito, Ilaria. Behind us, they can't be seen. And now, let's come to the Q&A session. Good afternoon, everyone. There is one question coming from Gianfranco, who says, thank you for those reconforting news. I have a Becker dystrophy, a nonsense one. That is my mutation, the nonsense mutation. I would like to know whether there are any improvements in terms of research with respect to this kind of mutation in particular. And I do hope that soon, as I said, he's going to get the materials. We just said it, we confirm it once again. He will soon get the documents and the Becker guidelines. And Fernanda was recently hinting at some time ago, and she was showing them. So many thanks again to Fernanda. She was in charge, together with Professor Pecoraro, the making of the guidelines and of that document, so important document. Now, I don't know if there is anyone who'd like to answer this question. Well, maybe I could. Sarah. Good. Thank you for your question. Givinostat is not for a specific mutation. It can be used for all Becker patients. And in our study as well, I don't really recall whether we had patients with a nonsense mutation, but definitely there were no restrictions, no limitations as to the genetic mutation. In other words, yes, it could be utilized also for the nonsense mutation people. Another question, still for Sarah. Would you envisage having a phase 3 trial soon? And if yes, would you envisage involving other centers in Italy? Thank you for this question. Well, the company is waiting for the Duchenne results, and then soon you will see our Duchenne plan. The results will be ready by January this year, and on the basis of the results, we will decide the further developments for the Duchenne and Becker. So the idea is definitely of having an extended enlarged work, a phase 3-1, and we had so many difficulties in recruiting patients. So this is going to be a multi-center study because many more centers will participate in Europe and in the USA. Question for Professor Pecoraro now. How will they be recruited? I mean, the patients, how will the patients be recruited? And if yes, is the parent project register going to be considered? In the first place, let me say that whomever would like to take part in the study should contact our center and let us evaluate and assess the eligibility for that study. We have patients in Padua. We've been treating them for so many years, so they will have also the possibility of being part of that study. There is going to be a possibility of considering the study. This is a study, a pilot study, that will allow for the participation of 39 patients from Europe and the US. So this is a limited study in this phase, but it's an important study because should it ever reach and achieve the goals that were set, there will definitely be an enlarged phase 3 study coming after it. And in that case, the numbers of patients is going to be incredibly relevant. Thank you. Well, yes, we will get in touch in the next months. It is going to be beautiful to organize a webinar in the very moment when the study will become operational in your own center, so as to inform adequately all of the families. And now again, another question for Professor Pecoraro. Would you say that there is going to be a trial that could be launched for the Duchenne in your center as well? Well, as of now, there is nothing that's been planned in that sense because there is no approval of the drug. The drug is not to be prescribed yet. There is no authorization. Our center was not part of the centers that were initially recruited. There have been some issues that were more of a bureaucratic and administrative nature in the non-selection of Italian centers, I would like to say, and specify that. Again, another question for you, Professor Pecoraro. A patient is asking, do you envisage muscular biopsies in that trial? No, says the professor, only blood draws and clinical assessments, nothing else. Perfect. I forgot to say that apart from blood drawing and sampling, we also sample saliva, all of them non-invasive procedures, because we've been so much used in testing ourselves in the past 2 years. As far as the Edgewise study, a patient is asking, Joanne, this is for you. A patient is not sure he got the mechanism right in terms of the MOA, the mechanism of action, meaning how that drug is acting and affecting the muscle contraction. Could you please try and re-explain that in just a couple of words, in simple terms, possibly? Thank you.
So it is a different approach. And we know that you've been hearing so much about dystrophin and its function. Why are we targeting myosin? And the problem is that, in particular, these fast muscle fibers are very much stressed, overly stressed, because of the lack of dystrophin. So you saw in the video that the muscle with EDG 5506 is contracting. It's doing exactly what it's supposed to do. It has its function, but it is protected because those fast muscle fibers are just tweaked a little bit to be able to protect them. So it doesn't decrease the strength of the muscle. In fact, we measured the strength in the Becker patients, and we found that with hand grip was what we were measuring, that was completely preserved, even in the patients that had that were the weakest at the beginning of the study. So strength stays the same with EDG 5506. It's there to protect those fast muscle fibers.
Grazie mille, Jen. C'è un'altra domanda che leggo, arriva da Antonio Bellan e chiede: il vamorolone potrebbe sostituire glucocorticoidi come il deflazacort in pazienti già in trattamento con questi ultimi?
Ciao Antonio, buon pomeriggio. Allora direi senz'altro sì. Nel momento in cui se ne è dimostrata l'efficacia.
Yes, Antonio, in the very moment when we have proven the efficacy, we will have a switch from a glucocorticoid to the steroid. In the clinical study, in order to be readable, the patient should not have taken glucocorticoid for at least 3 months. That means that we need a washout period, discontinuation period on the basis of the protocol that was explained in the previous session. One very last question now. The question was, are 6 months sufficient to see the result? And I guess that this relates to the varolonone study. And we heard that the variability with the Becker, as we've heard, is very high. And this is unfortunately a complexity that needs to be considered in the clinical studies. So this person was wondering whether 6 months are sufficient, or a sufficient period. Hope, yes. Certainty, not existent yet. We don't have any certainty. We are exploring the situation. The goal is exploring the situation, but the indication is that we have no certainties as to the possibility of detecting a change in such a short period in patients who are not going to be selected on the basis of the type of deletions, so we cannot really predict the clinical trend and course. And we defined the North Star parameter, which is something I believe that we could see ex post, probably. Many thanks. Maybe Gloria would like to ask a question. Yes, this is a question for Joanne. And I think that the question is, EDG 5506 will be utilized for all types of mutations, as, for example, a deletion ranging between exon 3 to the 7th in the Duchenne. It says Duchenne, but I was wondering maybe whether there was a mistake in that. No. It's the Duchenne. So I confirm. 3 to 7 means Duchenne. Joanne, yes. Can you answer?
Yes, we anticipate for all mutations, because the problem with all mutations is the relative or complete lack of dystrophin function. So it's a range of diseases, basically, a range of the disease between Becker and Duchenne. So we anticipate it would work in both, with all mutations.
Perfetto, grazie.
Perfect. Many thanks. Questions, I think we are done with them. But I have a curiosity. Let me ask one thing. How broad are the natural history studies having to do with the Becker dystrophy? Because in the past days, during the previous presentations, we've heard updates about so many clinical trials, and we saw that only too often there were some external control groups and some comparison groups. Comparisons were made with the different matches existing between the characteristics of one patient and another. I believe that this is helping us, but in a pathology or a condition like the Becker, what are the data? How many data are available to us? And then how, in terms of association, patient association, can we help provide more solid data in a disease which is so heterogeneous and so diverse in the different types of patients? How can we prove of some help? Well, I don't know if I can comment. I think we hit the mark. The natural history of the Becker are not complete. They are valid, but they apply to small groups. But let me say that we financed a Teleton group just to allow for a Becker dystrophy, and I would like to say that all Italian centers participate, especially the ones having to do with the management of the patients. And the preliminary data are retrospective, especially on the 700 patients with the Becker dystrophy. Now, I would like to have a new study, which is about to start, to follow them prospectively in the next 3 years. And when the study will come to completion, it will be representing probably a reference point for the natural history of patients with the Becker. I believe that this is an excellent piece of news. I don't know whether Sarah or Joanne would like to add anything to this.
Yes, actually, Edgewise, well, first of all, there is the wonderful data from Elena and Luca's group, and also the Netherlands. Eric Nix has a great natural history study as well. Edgewise is, certainly realizes that it would be good to have more, and Edgewise is sponsoring a natural history study predominantly in the United States with the GRASP academic group to gather more natural history data with MRI and functional measures, biomarkers, to get more information and to put all of these trials in context. So that will be important information.
Grazie mille. Sara, volevi aggiungere qualcosa anche tu?
Thank you very much. Sara, did you want to add anything? Yes, I wanted to say that I completely agree with Dr. Pegoraro. There are databases. They are somewhat reductive, unfortunately, in terms of the longitudinal scope, the time in which data is collected. Italy is doing a lot, and more robust data is available. And as Joanne said, Dr. Nix too has extremely good data regarding RMI. So we need to think about a biomarker, since the progression of the disease is slow and it's difficult to identify the functional endpoint. Thank you. Thank you very much. Thank you, everyone, for the contributions that you've shared with us, for the updates. Just a reflection on one aspect that came out in recent days, but in the past too, i.e. how wonderful it is for clinicians to work together in the Duchenne community nationally and internationally. All of this really helps to speed things up a great deal. When people work together, associations of patients like ours, this is really an added value that is provided, because this is a very special community. Thank you once again to you all for being with us, for connecting. Thank you, Gerardo. And we have a message to convey, right, Gloria? Do you want to say it? Yes, we're going to take a short break now, but we invite everyone to stay connected. And at 4:30, we will begin the next session, session number 8, with all the strategies downstream in order to improve muscle and reduce inflammation and necrosis. And we're going to have a material on clinical trials. We put this together last year. It's a really interesting video, which I invite you to view, how it explains how a clinical trial works. It has subtitles in English, so even non-Italian speakers can join in and can follow the video. You can just look at the subtitles in English. Right after that, right after the video on clinical trials, we will view the international documentary, which is also wonderful. It's material that we're very proud of. It's a documentary which, of course, was done with the contribution of our association. Other associations, European-wide, were also involved, and not just that, with a lot of very touching and wonderful interviews from the community. Many moms, many dads. It's really a wonderful document. So please stay with us. Maybe you can have a coffee or a tea and you can sit down and view these significant contributions. And see you at 4:30. It's going to be a very long session, but rich in substance and contents. So I hope to see you all. Once again, thank you, Professor Pegoraro. Thank you, Joanne Donovan, Sara Gazzaniga, and Giovanni Lauranzana. Thank you, one and all, for this interesting session. Thank you.
Avete mai considerato di far partecipare Leo a un trial, uno studio clinico? Si tratta di una ricerca medica, che serve a comprendere se un farmaco può essere utile per trattare una patologia.
Quindi non è una cura?
No, però è un passaggio fondamentale nella ricerca di nuove terapie. È l'unico modo per stabilire se un trattamento ha un effetto sulla patologia e se è sicuro per la salute dei pazienti. Il percorso di sviluppo di un farmaco è lungo, può durare fino a 10 o 12 anni e può interrompersi se il trattamento non risulta efficace o se ci sono effetti collaterali inattesi. Inizia con esperimenti in provetta o su cellule e prosegue nei modelli animali. Se i risultati sono positivi, si passa alla valutazione nei pazienti attraverso i trial clinici, articolati in 3 fasi, nelle quali va trovata la risposta a una o più domande via via più complesse.
Ora mi è più chiaro, ma che vantaggi avrebbe Leo dalla partecipazione?
Allora, tenete presente che se il farmaco si rivelasse efficace, partecipando al trial, Leo potrebbe beneficiare prima di un trattamento innovativo e il suo stato di salute sarebbe costantemente monitorato da medici specializzati esperti nella patologia. Partecipare a un trial vuol dire anche aiutare la ricerca, perché a prescindere dall'esito, le conoscenze sulla patologia migliorano, portando un beneficio a tutta la comunità di pazienti.
Sì, certo, ogni conoscenza in più è preziosa, ma quali rischi ci possono essere per la salute di nostro figlio?
Dobbiamo sempre avere in mente che uno studio clinico è un esperimento. Non è garantito che dia gli effetti sperati e c'è la possibilità di effetti collaterali. Anche se la salute del paziente viene sempre al di sopra di tutto ed è tutelata con controlli clinici frequenti e approfonditi, bisogna tenere in considerazione questo rischio. E va considerata anche la possibilità che nel corso del trial si assuma il placebo al posto del trattamento.
Sì, ne ho sentito parlare, ma non so bene come funzioni.
Certo, vi spiego meglio. Spesso uno studio clinico divide i partecipanti in 2 gruppi. Tutti i pazienti fanno gli stessi esami e visite, ma mentre quelli di un gruppo ricevono il trattamento, gli altri, il gruppo di controllo, ricevono un trattamento simile nell'aspetto, ma che non contiene il farmaco. E questo è necessario per essere certi che i risultati raccolti dipendano veramente dal farmaco e non da altre variabili.
Quindi come funziona il reclutamento?
Beh, i pazienti che partecipano a un trial devono costituire un gruppo omogeneo. Quindi, per farvi capire, oltre all'età, ai farmaci assunti e in alcuni casi il tipo di mutazione, occorre anche verificare che tutti abbiano alcune caratteristiche cliniche comuni attraverso esami del sangue, prove motorie e altre valutazioni. Noi medici, inoltre, dobbiamo capire se a livello pratico il paziente e i familiari possono sostenere questo impegno. A volte un bambino o un ragazzo non viene scelto ed è normale sentirsi delusi. Ma non bisogna mai dimenticare che questo rigore è importante per ottenere risultati chiari e accedere al più presto al possibile trattamento. Quando il parere è positivo, il medico leggerà insieme alla famiglia il consenso informato, un documento che spiega le finalità dello studio, i tempi, come funzionerà, i possibili rischi e gli aspetti organizzativi. Ci sono tante cose da capire bene prima di firmare questo documento e iniziare il trial. Per esempio, bisogna sapere se partecipando a un certo trial si perde la possibilità di accedere ad altri studi in futuro.
Ci sono tanti aspetti da valutare. Non è una decisione facile.
Dobbiamo capire se possiamo farcela a livello pratico. Dovremo prendere dei giorni dal lavoro e Leo dovrà saltare dei giorni di scuola. Poi bisogna capire gli effetti della terapia nella vita di tutti i giorni.
E dovremo discuterne bene con Leo. Per fortuna abbiamo già parlato un po' con lui della patologia. Il consenso informato lo dovremo firmare noi e anche lui. Leggendolo ci farà tante domande. Dovremo essere sicuri che se la senta.
Forse potremmo anche parlare con una famiglia coinvolta in un trial. Chiamiamo Parent Project. Loro ci possono dare dei consigli per decidere e ci aiuteranno a confrontarci con altre famiglie.
Quindi esistono diversi modi di assumere il trattamento?
Sì, dipende dal trial. In alcuni casi si prende una pastiglia o uno sciroppo a casa, in altri il farmaco viene somministrato una o più volte nel centro clinico.
E poi mi hanno detto che dovrò andare a fare tante visite.
Sì, di solito si passa una giornata nel centro clinico e si fanno una dopo l'altra le varie visite, insieme a un genitore. Per darvi un'idea, possono essere prelievi di sangue, test funzionali, test come l'ecocardiogramma, la risonanza magnetica o anche una biopsia muscolare. Nella biopsia muscolare viene fatta una leggera anestesia e poi un piccolo taglio sul braccio o sulla coscia per prelevare e analizzare una parte di muscolo. Al risveglio ci saranno dei punti e si può sentire un po' di fastidio. La risonanza magnetica invece è una specie di fotografia generale di tutti i muscoli del corpo, fatta dentro a una macchina, simile a una navicella spaziale, dal rumore forte, nella quale occorre restare fermi. Qualche volta la giornata risulterà faticosa ed è bene portare con sé qualche passatempo.
Siamo preoccupati per il fatto che Leo perderà diversi giorni di scuola e anche noi con il lavoro ci dobbiamo organizzare.
A me non dispiace perdere qualche giorno di scuola.
Sì, prima di decidere vi consigliamo di spiegare la situazione alla scuola e al datore di lavoro. Mamma e papà possono fare domanda per i permessi necessari per venire con te a fare le visite e gli insegnanti e i compagni possono aiutarti a non rimanere indietro.
Riguardo alle spese abbiamo dei dubbi. Ci sono dei rimborsi?
Sì, di norma è previsto il rimborso di tutte le spese legate al trial, come viaggio, vitto, alloggio. Ecco, potrebbe accadere che venga chiesto di anticipare queste spese, che poi vengono rimborsate, mentre in altri casi c'è un sistema di organizzazione che provvede a tutto.
E se avremo dei dubbi potremo parlare con lo staff che segue lo studio, vero?
Assolutamente sì. Sarà bene parlare con l'equipe, sia voi sia Leo, quando vi verranno dei dubbi o delle domande da fare. Potrebbe venirvi voglia di capire se Leo sta assumendo il farmaco oppure il placebo o se il farmaco stia facendo effetto. È normale volere queste risposte, ma riguardo a questo è necessario aspettare i risultati dello studio.
Per un genitore è normale avere speranze, come quella che il trial possa contribuire a rallentare un po' la progressione della patologia. Alcuni momenti possono essere vissuti con frustrazione, ad esempio se non si sono verificati miglioramenti, o ci sono stati effetti collaterali, o se i sintomi della patologia diventano più evidenti. A volte capita che un trial venga interrotto per motivi legati all'efficacia o alla sicurezza. Questo è sempre un momento delicato ed è normale provare rabbia e delusione. Anche se è difficile, bisogna sempre ricordare che il trial è un percorso di sperimentazione condiviso che si affronta per aiutare a rendere disponibili nuove terapie in futuro.
Le emozioni, sia di Leo sia dei suoi genitori, sono importanti. Le aspettative, i timori, la fatica dei genitori possono influenzare molto il modo in cui lui vivrà questa esperienza. Alcuni bambini provano paura o ansia per alcuni aspetti delle visite o per i possibili effetti collaterali. Altri affrontano con relativa serenità questo impegno. Spesso la partecipazione al trial porta i pazienti a confrontarsi con la propria condizione, a porsi e porre delle domande. Un dialogo aperto su tutti questi temi aiuterà Leo a comprendere tutto ciò che sta vivendo.
So in 1984, a long time ago, my boys, two of my boys, my only two sons, were diagnosed with Duchenne muscular dystrophy. So at that moment, you feel quite alone and really unknowing about what happens next or what you should do. So I reached out to physicians, and most of them had never even heard of Duchenne, or if they'd heard of Duchenne, it was very briefly in their medical school career.
La distrofia muscolare di Duchenne è la più complessa tra le patologie genetiche che riguardano il muscolo. Di fatto è presente dal concepimento, quindi alla nascita tutti i bambini che hanno la distrofia di Duchenne di fatto già la portano con sé, e compromette la rigenerazione del muscolo. Tutti noi utilizziamo il muscolo, qualsiasi cosa facciamo, ma noi lo ricostruiamo quotidianamente. I bambini che hanno la distrofia no.
So I went on this journey to find that out, and it took some time because people, it was hard to find and there wasn't much research. And so I felt like what was missing in this whole environment is the patient voice, right? Because parents, and certainly boys with Duchenne or individuals with Duchenne, have to have a voice in here because it's about their lives and about the quality of their lives. So I felt that was really missing.
Io credo che come tutti i genitori che ricevono una diagnosi di Duchenne per il loro figlio, la prima cosa che si cerca di fare è di cercare informazioni. E quindi Parent Project in Italia è nato per questo.
It was really hard to find out because, first of all, way back then, which seems like the old age, right? We didn't have social media, we didn't have Facebook, we didn't have the ability to connect to other families.
Nel corso di questa ricerca entrai in contatto con alcuni genitori americani, in particolare con Pat, e allora decisi di aderire a questo movimento internazionale che stava nascendo, che si chiamava Parent Project.
So I took a loan out at the bank, and then I ordered all the publications around Duchenne to understand what we knew about Duchenne. And then I made appointments at different laboratories and different clinical offices and pretended to be a doctor and asked them questions about what do we know about Duchenne.
Quindi in quel periodo la cosa più difficile è stata proprio esattamente capire cosa fare e come farlo, quindi cosa spiegare alle famiglie, come insegnare alle famiglie ad affrontare questa malattia da un punto di vista clinico e soprattutto anche da un punto di vista psicologico.
So I think the fundamental issue is that this child is the same beautiful child and that their path is going to be far different than anyone predicts because it's unknown but full of promise.
Una, dos, tres.
I'm Elizabeth, and I'm the mother of Justus. Justus is now almost 28, 27 and something. And I live in Amsterdam, or we live in Amsterdam. Justus is my son with muscular dystrophy, which we know for a long time already. And meanwhile, he's just doing whatever he likes to do, and I'm also doing what I like to do.
I'm Laura, and
and I live with my husband Philip and our wonderful 2 boys. Louis is 7 years old and Jensen is 5 years old. We live in a little small village, Lancashire. It's very, very small.
Mi familia está compuesta por 3 personas, que son Isaac, que es el papá de Alonso, Alonso y yo, la mamá.
Suntem o familie normală, de oameni obișnuiți, avem 25 de ani de căsătorie și suntem 2 oameni care au avut vise foarte mari în viața lor, au făcut sport, au călătorit, au iubit natura, o iubim în continuare și avem un băiat minunat de 21 de ani, Petru, care este centrul atenției și preocupărilor noastre.
אני טלי קפלן, אני נשואה, יש לי 3 ילדים, עידו הקטן, בן 10, שירה בת 15 וחצי, ואורי בן 14.
Alonso no hacía por querer estar de pie cuando todos los niños empezaban ya como a trepar y sobre todo a la hora de sentarse, tardó mucho en sentarse y cuando se sentaba se caía para atrás. Yo le tenía que poner cojines detrás para que no se cayera.
We went to see another consultant and we all got into the room and he got Louis pressing and running and he just came out with the words where he's got muscular dystrophy, Duchenne. And from that moment on, I don't think I heard any other words.
First thing I thought was, did we have time? No, he had a twin sister and she died after 4 days. Then I thought with Duchenne, you know, it's a shorter life, but it's still, we have 20 years ahead of us. So we're going to make the best out of it. So I remember when we drove down back from the hospital, I said to him like, we have time, you know, we have time. We're going to make the best out of it.
El caso es que yo pensé que durante unos meses no quería relacionarme con nadie que tuviera Duchenne, ni quería oír hablar de asociaciones, pero una vez que pasaron todas esas fases, despierta una fortaleza que no sabías que tenías. Eso es lo que me ha pasado.
אבל מצד שני זה משנה את כל החשיבה שבעצם אתה מבין שהמטרה היא מה שנקרא לייצר חוויות ולחיות. ושהרבה דברים בעצם לא תלויים banu.
Și din acel moment, de la vârsta lui de 6 ani, am decis să fac din mine cel mai bun părinte posibil. Și cel mai bun părinte posibil era părintele care investește timp, atenție și care este el însuși foarte echilibrat.
When Justus was just diagnosed, I thought, like, can I still laugh, you know, and have fun when your child has such a diagnosis? But then I realized that if he would have Duchenne and a depressed mom, that he would have a double problem.
Yo creo que feliz, yo creo que él está bien, tiene amigos en el cole, tiene amigos aquí en el barrio y él juega, le gusta jugar muchísimo al fútbol y yo le veo feliz.
Louis a lovely little boy, he's a character, he's always smiling. We have fun.
Y lo que cambió sobre todo es nuestra forma de ver la vida. Es decir, dar menos valor a cosas que antes eran muy importantes y que significaban verdaderos problemas para nosotros, y en ese momento todo pasó a ser un segundo plano y nos dedicamos a vivir el día a día y a disfrutar de Alonso.
Petru este un tânăr foarte pozitiv. Este un tânăr... Pentru mine, Petru este ca o lumină. Este capabil să înțeleagă lucruri profunde doar dintr-o singură privire. Este atent la suferința oamenilor din jurul lui.
So when Justus was young, I realized a few things. One is that he should be resilient. You know, if a child is afraid for everything and goes home or stays at home, that would not be good for his future. Second is that the way you're treated is also 50% is yourself. Justus just graduated from university, and he always, for him, it was very important. He just wanted to do things normal. He never wanted Duchenne to be too big in his life or to change his life too much.
כשהוא היה בכיתה א', רציתי בעצם לדעת מה באמת הוא יודע, כדי לדעת מה להגיד לו. ואז גם בבית הספר הוא התחיל לקבל טיפול רגשי, כדי באמת, הוא התחיל אז יותר להתמודד עם התסכולים ועם הקשיים הפיזיים יותר, אתה מתחיל בעצם לראות שקשה לך יותר לרוץ, או שכולם רציקים יותר מהר ממך ואתה לא...
Y aunque parezca ridículo para muchos que están viviendo ahora Duchenne en sus peores fases, después del diagnóstico, que ese es el varapalo más grande, fue en el momento que tuve que asumir que Alonso tenía que empezar a tomar corticoides, porque es una forma de decir que la enfermedad ya está aquí.
Petru a suferit cel mai tare când a fost părăsit de prieteni, în momentul în care el n-a mai putut merge. Încât s-a închis, a refuzat să mai iasă, a refuzat să mai meargă la școală, a refuzat să mai vină oameni la el, să mai lege prietenii, a preferat să aibă prietenii virtuale pe aceste forumuri de discuții. Camera lui e universul lui și să nu-l mai deranjeze.
My anxiety, it is still there. It is. I don't cry no more. I probably cry every couple of months. I have a really bad day, but I've learned to deal with it now. It's there.
המסר המשמעותי להורים החדשים שמאובחנים זה שהם לא לבד, שאנחנו כאן איתם, ושהעולם של דושן ובקר משתנה. והדבר הנוסף הוא שהשמש עדיין זורחת. זאת אומרת, עם כל הקושי, הילד שלך הוא עדיין הילד שלך, עדיין המטרה היא שהוא יהיה שמח, שהוא יהיה ילד, לא צריך להפיל עליו את כל הקושי הזה של המחלה, ולא להסתכל על כל מה שכתוב, אלא לחיות כאן, לחיות עכשיו, ופשוט ליהנות ושוב, ולזכור שהוא ילד, ללכת לגן שעשועים, ואתם לא לבד.
Odio Duchenne. No ha aportado nada positivo a mi vida, solo conocerme un poco más.
Everything they get, next step, they never can go back to a better level. So that's the bad part, I think.
El tiempo que no se lo estamos dando ahora es porque estoy segura que van a disfrutar de él más adelante, porque estamos luchando para ello, para que cada vez Duchenne esté más lejos de nuestras vidas.
Time isn't on our side for our boys with Duchenne. We need drugs, we need them now. We haven't got tomorrow, we need them today.
Here in the Netherlands, we have good things and bad things. What is not good is that drugs for Duchenne are not reimbursed.
În acest moment, situația generală pentru pacienții Duchenne în România este destul de inegală la nivelul întregii țări. În general, cred că povara bolii, povara dizabilității cade pe umerii familiei. Cel mai valoros lucru și cel mai pozitiv lucru din viața mea, care s-a întâmplat datorită distrofiei musculare Duchenne, este valoarea fiecărei clipe împreună. Valoarea dialogului simplu și uman cu oricare dintre interlocutorii tăi, indiferent în ce poziție de putere sau de decizie se află el.
Yo creo de verdad que Alonso no va a vivir todo el desarrollo de Duchenne que ahora mismo conocemos. Quiero confiar en que todos los avances que hay ahora mismo, si bien la cura está lejísimos, sí que vamos a ir poniendo parches a Duchenne.
These boys are not afraid of what's happening to them. Where should we be afraid for? When your child's in a wheelchair, he's still the same boy, you know? He's still the nice kid, and that continues. So don't be afraid. And as I said, I feel that I became quite fearless because of this diagnosis, and that feels good.
They want to see happy mum and dad. They want to have fun because these little boys, they don't know what Duchenne is. They don't know what their life's going to be like. They just see today. They see going up the stairs to play on their Xbox. They see going to the park. You know, I think us as parents, we worry about what's going to happen next year or the year after. And I think just relax.
Tu hijo tiene Duchenne, pero tu hijo tiene un nombre, tiene unos amigos, tiene un colegio, es un niño. Entonces, disfruta de él y ve acompañándole en cada paso y ya está. Para luchar contra Duchenne, pues ahí tenemos a los científicos. Nosotros solo tenemos que dar cariño al niño, igual que cualquier padre. Y nada, y vivir con esperanza, nada más.
Noi nu ne permitem să amânăm pentru a doua zi lucruri. Noi nu ne permitem să spunem că ne vom lua revanșa față de copiii noștri, nu acum, pentru că suntem ocupați, mai târziu. Noi nu avem acest lux de mai târziu. Și asta a creat m-a adus pe mine să trăiesc mult mai bine în prezent și să încerc să mă bucur de fiecare lucru mic care mi se oferă într-o zi.
זה תהליך ארוך ללמוד לומר בזכות ולא רק בגלל, שהרבה דברים הם לא בגלל המחלה אלא בזכות, כי כן, דברים השתנו, מן הסתם זה לא משהו שבוחרים, בלי האבחון הזה, אז הכיוון של החיים היה אחר לגמרי, זאת אומרת, זאת הייתה לגמרי בחירה לעזוב את מה שעשיתי קודם, כי ההבנה היא שאם אנחנו כהורים לא נפעל לשנות את החיים של הילדים שלנו, זה לא יקרה. ואנחנו כהורים, כשיש לנו באמת את הרשת ארגונים הזאת ואת ההורים,
Hope is not only hope for a cure, it's also hope for a good life. It's hope to have fun, hope that things go well, you know, and also hope that what you do will help a lot of people. That's also my hope.
Pero no, o sea, la esperanza que nosotros damos no es una esperanza fingida, es que esta asociación desde el principio hemos tenido claro que teníamos que luchar con positivismo y esperanza, pero una esperanza real, yo no me la invento.
Be realistic about them. Don't be disappointed if there's not a cure tomorrow or something. And above all, I would say enjoy life. You still have a beautiful child.
Aunque mi hijo tenga 8 años y yo no sepa cómo, si voy a vivir ese final hombre, a ver, quiero vivirlo, pero si no es así y llega más adelante, sé que he hecho algo para él.
Be optimistic. Hope keeps you alive.
Buonasera a tutti, ben ritrovati.
Good evening, everybody. Welcome back. And today we close our international conference with a session devoted to strategies aimed at reducing muscle inflammation and fibrosis. So this is a long session. I ask the speakers to speak slowly for the sake of our interpreters, so that, simultaneous translation becomes easier. I wish to thank Sara Capponi, who's going to introduce all the speakers. She's a member of our board. And we start with slide sharing for my short introduction on the strategies and why we have all these strategies to improve muscle health, fight inflammation, and reduce fibrosis. We started our journey in this spaceship, trying to understand what happens when there is no dystrophin, and all the strategies that aim at restoring dystrophin. But we know that when dystrophin is missing, there is a cascade of events, and gradually there is a damage to the muscle, and then there is inflammation setting in, a chronic inflammation setting in. So gradually, there is inflammation, sort of a perpetual, never-ending inflammation, an increase in the adipose and fibrotic tissue. An image just to show you what happens in a dystrophic muscle versus a normal muscle. When, for example, you strain your muscle, you have a transient inflammation. So after a few months, the muscle regenerates and gets repaired, whereas the dystrophic muscle has a permanent inflammation, accumulation of adipose and fibrotic tissue. And there are many strategies that will be dealt with by our guest speakers to try and stop this inflammation and the formation of fibrotic and adipose tissue. Parents of our community know it very well. The guidelines recommend precisely to inhibit all these processes that are typical of DMD. We have glucocorticoids, cortisone, that at present is the gold standard as the only available therapy. Professor Pecoraro listed the benefits of this drug, of cortisone, and delay the loss of ambulation, reducing the risk of scoliosis, stabilizing the respiratory function, and prolonging life expectancy. So it is essential to administer cortisone as early as possible, around age 4. You are supposed to start around age 4 and then continue forever. Since January 2017, prednisolone, and deflazacort are paid for by the National Health System according to Act 648/96 for the treatment of DMD. This piece of legislation of December 96 foresees for these drugs to be paid by the National Health Service. So in order to respond to diseases for which there is no valid therapeutical alternative, thanks to this piece of legislation, glucocorticoids are used with an indication that is different from the usual one. But by doing that, we overcame a number of regional and local problems for the prescription of these drugs. So if you have the prescription of the deflazacort, according to this piece of legislation, our national health system pays for this drug that is so important for DMD. Very shortly, how do glucocorticoids work? An anti-inflammatory effect. They stimulate regeneration and tissue repair. They stabilize the phospholipidic membrane and they regulate the gene expression. There are side effects, we know, but these effects may be managed together with your clinician. They can be controlled and you can have an individualized adjustment of glucocorticoid therapy. Now, I'd like to give the floor to the other chairperson, Sara Capponi. She's a member of the board of Parent Project, and she'll be introducing the first speaker. And I'll see you at the end for the Q&A session. Sara, thank you for being here with us. Thank you, Gloria, and I wish to thank all participants. So the first speaker will be speaking about vamorolone. Eric Kaufman is the speaker. He's a professor of pharmaceutical sciences at the Binghamton University, State University of New York. Thank you for being here. We must also say that Professor Kaufman, together with Professor Kunkel in December 1988, published the discovery of the codified protein of the DM gene. Today, he will share with us the results of clinical studies on vamorolone. It is an analog of glucocorticoids that was developed with the aim of mimicking the action of glucocorticoids, but limiting the side effects of glucocorticoids. You have the floor.
Thank you very much. It's a pleasure to be here. And I love that video you showed the last half hour. So many of the people and my friends over the years, it was just a wonderful video. Thank you for doing that. Disclaimer, Santhera is publicly traded, although I represent Revirogen, and we're not publicly traded. As Elena Pegrado, my good friend and colleague, mentioned earlier for Becker Muscular Dystrophy, the glucocorticoids clearly show benefit in DMD, and she mentioned those, as did you heard earlier. But there's also these side effects. And so our goal was to try to determine if we could separate these, if we could retain or maybe even improve some aspects of the efficacy, but improve the safety profile as well. So this vamorolone was developed as a dissociative steroid. It's a steroidal anti-inflammatory, but it's not really a corticosteroid because all corticosteroids, including deflazacort, prednisone, prednisolone, and asthma inhalers, have at this one position, they look like this, but there's only one difference with vamorolone. They have an oxygen here, either as a double bond or an OH. And that oxygen is what vamorolone takes off, just that one letter from the steroid backbone. And that makes us different from all other corticosteroids. So that's the structural basis. It's a very mild change. But what we know is that change, when the drugs bind the receptor, their mechanism of action is to bind the glucocorticoid receptor. That's prednisone, deflazacort, and vamorolone. They all bind a receptor, and that receptor drug complex then exerts many activities within the body. And one of the good activities is to inhibit inflammation. So corticosteroids are potent anti-inflammatory drugs that are used in hundreds, if not thousands, of inflammatory conditions. So we certainly wanted to keep that activity because we feel that's important in Duchenne and hopefully Becker as well. It seems so in the muscle. But our goal was then to reduce these side effects. And that one letter change changed many different activities downstream of the drug and the receptor complex. So first, it doesn't turn on genes so much. Prednisone and deflazacort turn on many genes of the genome, whereas vamorolone does less of that. Also, prednisone binds to a different receptor called the mineralocorticoid receptor that regulates salt balance in the body. So it can increase blood pressure because it has off-target effects. Vamorolone has the opposite action. It is like a plerinone or spironolactone, which are also used in Duchenne for heart failure later in the disease. So we have a different activity that we've added, which is a mineralocorticoid receptor antagonist. Another interesting change is that one oxygen is the site of two enzymes in the body, throughout the body, that change active to inactive, prednisone to prednisolone, deflazacort to prodrug. So there's this switch throughout the body to turn prednisone to active or inactive, deflazacort active or inactive, cortisol active or inactive. Vamorolone cannot be acted on by those enzymes because they require that oxygen. So that is another difference. So we want to see how these then work in clinical trials, and that's what I'll explain today. The first trials we did were in an open label trial in 4 to 6-year-old DMD boys that were not on steroids previously and enrolled into a dose escalation. So a broad range of doses from low dose to high dose. And what we saw, and many of these studies are now published, we treated them first for 2 weeks, then 6 months, then 1.5 years, and then 2.5 years. The 2.5-year paper was just published last month. And what we see is as we increase the dose, the benefit or improvement in strength outcomes and motor outcomes all improve. So this is different than many other drugs that you've heard about. Is a lot of the drugs are meant to stabilize the disease or slow decline. Here with the corticosteroids and with vamorolone, we're showing very quick increases, so within 24 weeks. So as I mentioned, the 30-month study was just published, and I'll just show in comparison to corticosteroids that very similar. We looked at both the Synergy DNHS study, Duchenne Natural History study, which was spoken about earlier this morning with regards to ataluren. We used the same data, and then we see very similar effect to corticosteroids. But the one big difference is height. Corticosteroids stunt growth, whereas vamorolone does not. We actually see an increase in growth. So at least for bone morbidities and growth, even in the open label studies, we saw a significant difference between prednisone-treated kids and vamorolone. So now I'll present the recently completed double-blind study. This was 121 DMD boys randomized, and they were in 4 groups: placebo 25%, prednisone 25%, and then 2 doses, low dose and high dose of vamorolone. And I'll first present the 6-month or 24-week study, but then the boys on prednisone and placebo crossed over to vamorolone in the second study. And so that was also completed. And then all the boys can enroll in an expanded access program for continued access to vamorolone. And nearly all boys chose, and their physicians and families chose, to continue treatment with vamorolone. So these are the endpoints. As you know, it's important to have a primary endpoint, sort of the single hand of cards that the trial is judged on. And then you have consecutive secondary and exploratory. And so what we saw is we met the primary and first 4 secondary outcomes. So time to stand 6 mg/kg vamorolone versus placebo. You see the placebo kids are declined or stable over 6 months, whereas both doses of vamorolone show these improvements. 6-minute walk, also both doses showed significant improvements, as did time to run walk. If we look at the exploratory outcomes, again, these are outcomes you've heard in other studies like North Star ambulatory assessment. Again, very strong evidence that vamorolone improves outcomes compared to placebo. Similarly for time to climb. So now if we look at those compared to the prednisone group treated at the same time, double blind, so none of the children knew if they were receiving prednisone or placebo or either the doses of vamorolone. Again, we see the placebo is stable or slight decline, and we see prednisone, which is the green here, shows these same benefits as vamorolone. And the benefits are very similar. Now, the 2 mg per kg, the lower dose of vamorolone, in some outcomes like time to climb and stairs and time to run walk is significantly lower. So the higher dose of vamorolone seems to be better or equal on all outcomes, whereas 2 mg per kg is similar on some, but a little less on others. So then what about the height and the bone? So we again saw the stunting of growth with prednisone over the 24 weeks, whereas vamorolone treated kids showed these improvement of growth. Now, Duchenne children are shorter even without prednisone. They're about the 25th percentile. But when you give prednisone or deflazacort, then the growth is halted or slows dramatically. Whereas vamorolone seems to show catch-up growth and then continues to grow normally. Interestingly, at this 24-week crossover period, after the stunting of growth with prednisone, they crossed over to vamorolone, you could see the reversal of the growth and the catch-up growth. So it seems vamorolone can reverse the bone issues of corticosteroids. And this fit with the bone biomarkers. So Elena mentioned osteocalcin and others. So here we see different bone biomarkers. Prednisone and deflazacort are known to decrease those significantly quickly, even within a day of treatment, whereas vamorolone does not, placebo does not. So this fits with lower bone morbidities. What about side effects in general? So this is a summary of corticosteroid-associated side effects, all sorts of different side effects that corticosteroids show. And again, you see less of those with vamorolone compared to prednisone. So a summary, this is a first-in-class dissociative steroid with lower incidence of cortico-associated adverse effects. The phase 2A open label study was 48 boys over 2.5 years. Functional improvements or stabilizations long-term. 90% of participants chose to remain on vamorolone through expanded access. The double-blind trial, placebo-controlled with prednisone, studied 121 boys over 1 year. At 6 months, very significant clinically relevant improvements across all the functional outcomes for a broad dose range versus placebo. And it was safe and well tolerated. Physicians reported fewer clinically relevant adverse events, normal growth trajectory, bone biomarkers were normal compared to prednisone, and reduction in mood disturbance. And we'd like to thank all the clinical trial sites in the double-blind study. As Professor Pegararo mentioned, we initially worked to try to get Canadian sites and just ran into some technical troubles. The study chairs, Michaela Guglieri at Newcastle, Paula Clemens at Pittsburgh. And I should mention we're currently enrolling in 2 new studies. As Professor Pegararo mentioned, the Becker study that's just in Italy and the US at Pittsburgh. And now we have an expanded age range study at just in Canada, 6 sites, 2 to 4 years and 7 to 18 years, both treated with corticosteroids and not treated. And lastly, to thank all the different governments and foundations that supported the vamorolone development over the last 10 years now it's been. And we are submitting the regulatory documents to both the FDA and the EMA to request to see if we can obtain drug approval based on these data. Thank you very much.
Grazie a lei, Professor Hoffman.
Thank you, Professor Hoffman, for your contribution. Very, very valuable. And now we move on to another molecule, ATL1102, acting on the inflammation in DMD, and updates on clinical developments, Annabelle-esque antisense therapeutics. It is an experimental antisense molecules that has been developed to inhibit the expression of a protein that is placed on the surface of some cells of the immune system, and it can facilitate the inflammatory process. This is an Australian company, and we have here Annabelle-esque. Thank you for being here with us. You have the floor.
Thank you, Sarah. Good afternoon, and of course, hello from Australia. So this is my disclaimer slide. Antisense Therapeutic is a publicly listed company in Australia. So as we said, we're an Australian-based company developing antisense pharmaceuticals. We have 2 drugs in our pipeline. And these are licensed through our technology partner, Ionis. Today, I'd like to provide you, as we said, with a bit of background on ATL1102 and why we are developing for Duchenne's and why we believe that our drug will provide another tool in the treatment for Duchenne's. Thank you for the introduction on inflammation and how it affects Duchenne's. So research has shown that chronic inflammation is driven in part by reactive immune cells, including those expressing CD49D T cells, that on entering the muscle set up these ongoing phases of inflammation. Specifically, it turns out that DMD patients have a greater number of circulating T cells with high levels of CD49D, and this is also associated with both more severe and rapid progression in Duchenne. Those who are also non-ambulant also show the greatest number of the CD49D positive T cells. So the idea is that can we modulate or suppress the CD49D expression to have a positive effect and reduce inflammation further? Corticosteroids also appear to have no effect on the CD49D T cell numbers and also do not modulate the CD49D expression. So ATL1102 is an antisense oligonucleotide drug designed to CD49D. So it's designed to interrupt the translation phase of the CD49D protein production. So by inhibiting CD49D expression on the lymphocytes, we can reduce their survival, activation, and also their migration into the blood, from the blood to the muscles, and hence reduce inflammation. In both Duchenne's and multiple sclerosis patients, we've been able to show that 1102 can reduce the CD49D T lymphocyte numbers in the blood, thus supporting its development to reduce, as a treatment to reduce inflammation. To date, 1102 has been evaluated in preclinical studies and clinical studies in healthy volunteers. We've had a study in multiple sclerosis patients and also a phase 2A Duchenne study in non-ambulatory boys. And these studies have moved us forward to establishing a phase 2B3 study in Duchenne's, which will be starting this year. Briefly, I'd just like to review some of the results from our phase 2 study before providing you with details of the upcoming phase 2B3 study. The phase 2A study met its primary endpoints and was safe and well tolerated. We observed positive effects across multiple measurements of muscle structure, function, and strength. The mean observed changes following the 24 weeks of treatment suggested stabilization and disease progression or a reduction in the decline that would normally be expected over a 6-month period. Also from MRI data, it suggested stabilization of the percentage of fat and also preservation of the muscle mass. We compared our data for the performance of the upper limb function or PUL assessment to comparable data in a natural history cohort. And what we see is that 1102 treatment demonstrated a significant improvement in the PUL score compared to what would be expected in the natural progression of Duchenne's. So following on from these positive results, we are progressing 1102 into the phase 2B3 study, which I'll now present. The study will be a randomized, double-blind placebo-controlled study evaluating 2 dose levels of 1102 in non-ambulant Duchenne boys. And they'll be treated for 12 months. We'll be conducting the study in up to 9 countries in Europe and the UK, with around 35 individual sites and investigators participating in the study. Following the randomized study, participants will be offered the opportunity to enter an open label extension study based on acceptable safety data generated in the randomized study. The study will enroll 114 non-ambulant Duchenne boys into the treatment arms, and these will be ATL 1102 at 25 milligram and 50 milligram, and also a placebo arm. Treatment is given as a subcutaneous injection, and this treatment is given weekly, and the doses will be either given at the study site during study visits or at home during the 52-week period. The study will comprise of a 4-week screening period, the 52-week treatment period, and then participants will enter either the open label extension study or a 16-week follow-up period. Briefly, the key study entry criteria include Duchenne boys who are non-ambulatory and aged between 10 to less than 18 years old with a body weight of at least 25 kilograms. They'll need to have a PUL entry score of greater or equal to 2, and participants can be on corticosteroid therapy throughout the trial, as long as this has started at least 6 months prior to the first dose and stable for 3 months as well, and have adequate cardiac and respiratory function. The primary objective of the study is to evaluate ATL 1102 using on upper limb muscle function using a PUL score compared to placebo, while the secondary objectives will evaluate upper limb strength, respiratory function, quality of life and safety, and pharmacokinetics. Assessments in addition to the PUL will include the Maya grip and Maya strength, Maya pinch. These evaluate hand grip strength as well as thumb index finger clamp strength. We'll also be looking at respiratory function, quality of life through questionnaires, as well as standard safety assessments. Blood samples for pharmacokinetic assessment and examining lymphocyte and T cell CD49D target modulation will also be undertaken. I'd like to thank the participants and investigators who have been part of the 1102 journey to date, and we look forward to working with the Duchenne community in moving 1102 into this new clinical trial. If you have any questions, please feel free to contact us at ANSI-Sense. Thank you.
Grazie mille a lei, Annabelle. Adesso passiamo al terzo.
Many thanks, Annabelle. And now let's go on with the third update on clinical study. Givinostat is the focus now. And now I'd like to pass the floor to Dr. Paolo Bettica, Medical Director of the Italfarmaco Group, the only medical company active on both Duchenne and the Becker. And he will be giving us an update as to the developments achieved with regard to Givinostat. Many thanks indeed for this kind invitation and for this yearly update on the development of Givinostat in the Duchenne dystrophy. My disclaimer, my name is Paolo Bettica. I am employed by Italfarmaco, manufacturing Givinostat, which is currently in the development phase. It's not yet available on the marketing in no place worldwide. And this presentation of mine is only for scientific purposes and disclosures. What am I going to talk about? Let's see. I will be once again recalling how is Givinostat working in the Duchenne dystrophy. I will present the results of the long-term results obtained with Givinostat on as regards the milestones of the disease, and I will also update you as regards the ongoing clinical studies. Let's see how is Givinostat working. What is the mechanism of action? at the beginning of the session, the resume given by Gloria was excellent, and we've understood that the absence of dystrophin comes with a double negative effect. This is a twofold effect. On the one side, as regards as the muscle is concerned, the mechanic action performed by dystrophin is missing. The muscle is thus being more frequently damaged. On the other side, it works in an inappropriate way, and this is referring to the repairing mechanism of the muscle, something which has got to do with a normal muscle, not the Duchenne muscle. And this is known as the restitutio ad integro, so the recovery of the muscular fiber. Then, well, all of these data have got to do with the DHCD, especially the HDAC2, sorry. We've seen an increase in the damage suffered by muscular fibers. We have seen a system, a repair system, which is not efficient. And the final result is that the muscle has been replaced by fat muscle, fibrotic muscle. And downstream of this absence of the dystrophin, we see the action of givinostat, which is opposing the degeneration effects provoked by the disease. If you well remember, the results have been already published, and they were proven already in the preclinical models on the MDX mice, but also in the phase 2 studies that were conducted on Duchenne boys, where at the end of 1.5 years of treatment together and in combination with corticosteroids, we did observe a significant improvement in the muscular biopsies of these boys. The results were then reconfirmed with magnetic resonance. And after 2 years, we compared them with a control group, an external control group, and we could then prove that the infiltration of fat and atrophy were reduced in those patients treated with givinostat. Another important aspect, which is important to mention, is that since we have been studying it in a concomitants of different conditions, we have now acquired a sufficient, important amount of data, which makes us understand what is the degree of tolerability of givinostat. We have collected data out of more than 600 subjects treated in clinical trials with different indications, and of the 600 treated patients, more than 500 are boys and children having a Duchenne dystrophy. So as far as the side effects, so we know what are the frequent ones. The reduction of platelets is the first one. And I feel the urge of stressing that, once again, we have reductions that are either mild or moderate, and that the events are visible in the lab because we see the low count of platelets in the laboratory, but that this fact was never associated to the most important events, such as bleeding, in the absence of platelets. So for the time being, this is an adverse event which is known, but that we can manage thanks to the adjustment of the dosing. Another frequent adverse event is diarrhea, which once again, in this case, is easy to manage with the dose adjustment. Last but not least, let me say that we are now monitoring the possible increase in triglycerides in the blood. Let's now take a look at the results that were collected in the long term. You probably remember that the boys that were included in the phase 2 studies were then accepted and switched or crossed over into an open label study. So we continue to treat these boys, and every 4 months we allowed them to undergo tests in the centers that recruited them so as to assess the tolerability of the drug, but at the same time, its possible efficacy. We can then say that it is possible to see how a long-term treatment with givinostat in combination with corticosteroids for more than 7 years by today, or as of today, could entail an effect on the milestone, on the disease milestones. that means entailing important events in the evolution of the disease. First and foremost, the loss of ambulation. We can compare our results with the ones that were published by the Synergy Group. You can see this on the left-hand side of the slide. And here you see that the average age or the mean age at loss of ambulation in the Synergy study was equal to 13 years and a half. But if we duplicate the same exercise with our own boys treated in the phase 2 study, and again in its own extension, and they were treated for more than 7 years, we see that the mean age in terms of loss of the ambulation is 16 years. Now, if we are not wrong, this suggests at least a couple of years delay in the loss of ambulation, especially whenever the children and the boys are treated with Givinostat plus steroids. The other thing that can also be done was and is the one of assessing other benchmarks, which are important as the age grows and increases. The first one being the respiratory function. As you probably have heard, this is done thanks to the spirometry test, whereby benchmarks and parameters are assessed, such as the FVC, the forced vital capacity. And in other words, this means how much the lungs are filling themselves with oxygen, and the expiratory flow at the highest level, which is what is instrumental to measuring the function of the breathing muscles at the diaphragm level. We well know out of natural history studies, we well know that these benchmarks and parameters tend to decline by some 5% each year that goes by, year of age. And this is especially so in the boys aged starting from 10 years. And if we duplicate the same exercise for Givinostat and with Givinostat, we see that the boys treated with Givinostat plus steroids is indicative that the FVC decline is equal to 1.7% yearly, which means less than 5%, which I mentioned before. And then if we then take a look at the right-hand side of the slide, the peak expiratory flow is not indicative of any decline, and instead of 5%, which is what I mentioned before. So let's see, where do we stand now with clinical studies? As you probably know, the clinical pivotal study, the most important one for the registration of the drug, is EPIDIS, the study known as EPIDIS. This is a randomized study, double-blind, where the boys that were met with exclusion criteria of the study were randomized in a 2-to-1 ratio, meaning that they receive Givinostat in 66% of the cases, plus placebo is then received in 33%, and then they are followed up for a total amount of time of 18 months. During the 18 months, as you can see in the lowest part of the slide, the visits or the times they call on the center are frequent because they need to adjust the dosing, and then they are being reviewed every 3 months up to the 18th month of follow-up. Then at the end of the study, those who wish to do so may access an open label study where the boys are then followed up until the approval on the market for the country to which they belong. It is important to stress that almost all boys included in the EPIDIS studies were then crossing over into the other study, the extension study. Another important study is including functional tests, the 4 steps, which is the primary endpoint, the 4-meter walk, and all of the other benchmarks, functional benchmarks that we did mention. We also measure the strength And then I believe that this is the only pivotal study which is also measuring the MRI of the muscle in order to check the infiltration of fat test at baseline 6 months and 18 months. This is the scheme of the design of the open label study, where all of the boys that were treated with the Givinostat at the time of the clinical study, this is the study where they can access, and the primary goal is the evaluation of the safety in the long term of Givinostat. But as I said, every 4 months, functionality tests are taken in terms of the ambulatory and the upper limbs and the respiratory function level are concerned. Now, where do we stand? As you probably recall, the EPIDIS study had an interim study, and that was because of predefined criteria, and should the criteria be met, then the study would have been placed in a halt, and which is not what happened. So we went on with the enrollment, and in total we enrolled some 169 boys, 179, sorry, boys, and all of them completed the study with one exception. So we do expect further results to be available by the month of June this year. Having said this, let me thank all of you, and most of all, the DMD boys that took part in the studies and their families as well, because they did an exceptional work together with the clinical centers that were fully involved, notwithstanding the COVID pandemic. Let me also thank the many associations that are here mentioned, which were proving to be of incredible help. And as usual, on the bottom part of the slide, you will find the contacts and the email address to which you could send the request of possible information. Many thanks.
Thank you. And now an update on clinical studies. EWA carrier from Fibrogen with pamrevlumab. There are some clinical studies with this molecule that is meant to fight fibrosis. Parent project patients registry contributed to the recruitment of the patient for both studies that will be dealt with by Dr. Carrier. Thank you for being here with us. You have the floor.
Thank you very much. Sarah, do you see my slides?
Yes.
Thank you. My name is Eva Carrier. I'm Executive Director of Clinical Development, Fibrogen. I ran 2 phase 3 clinical trials, registrational trials in Duchenne muscular dystrophy. I'm speaking from San Diego, California. So good morning here, 8:21, but good afternoon to all of you. Briefly, I will present progress on our work in Duchenne muscular dystrophy, which started a few years ago. Our company Fibrogen is based in San Francisco, California. I will be speaking briefly about the MOA, mechanism of action of our drug, previously known as FG-3019 and now pamrevlumab. Because it's a novel mechanism of action and
sorry. Scusami Eva.
Yes.
Potresti condividere le slide a schermo full screen, per favore?
Could you share the slides full screen, please?
Grazie mille.
Do you see full screen? And I will also speak in details on the ongoing phase 3 study of pamrevlumab in patients with ambulatory DMD. The Lelantos 1, which was in non-ambulatory DMD, phase 3 registrational trial, just finished accrual. Before I go there, I wanted to show you the level of CTGF, connective tissue growth factor, in skeletal and cardiac muscle of patients with DMD. And on the left side, you see that in the blue bar, the CTGF, connective tissue growth factor in these patients, is elevated. And you can see the gray bar here, which is in normal patients. So this elevation is pretty significant. And I would like to show you that this CTGF here in the yellow box drives the myofibroblast differentiation and activation. And this leads to ECM deposition and at the end, the last box, fibrosis. So this is what's happening also in the muscles of patients with Duchenne muscular dystrophy. And pamrevlumab, FG3019, it's a human recombinant monoclonal antibody, fully human, which is produced by Chinese hamster ovarian cells in the big tanks. So it's a pure protein that neutralizes CTGF. So jump forward, this neutralization may contribute to decrease of fibrosis and regeneration on the muscles. And that is the hypothesis that we are working with in the phase 2 that's finished, and 2 phase 3 trials. So this is the summary. We do know that the muscles of patients with DMD become fibrotic and they are weaker. They are weak, and this is the problem the boys have. And so we have muscle weakness and injury. And the FG3019 or pamrevlumab, as I mentioned, inhibits CTGF and perhaps will decrease the muscle fibrosis, slow muscle injury, and enable retention of muscle function or prolonged decline. And again, this is a hypothesis. We don't have approved drug yet in any indication in any country with pamrevlumab. We have ongoing phase 3 trials in pancreatic cancer, idiopathic pulmonary fibrosis, and 2 phase 3 trials in DMD. So again, this is important to understand, so I don't want to overstate the results because they will be confirmed in the ongoing phase 3 trials. So we do have ongoing trial 094 in ambulatory DMD. The 093 study, which was Lelander's one, just finished accrual with 99 patients. So we don't accrue, it's close to accrual. But phase 3 study is ongoing with 5 open sites in Italy and 3 sites that were accepted for this trial. So there's ongoing work to open them up. So it's a phase 3 randomized double-blind trial of pamrevlumab or placebo, double-blind. And this will be, of course, in combination with systemic corticosteroids, which are standard of care in ambulatory subjects with Duchenne muscular dystrophy. And the age of these patients will be 6 to 12. And the goal is to enroll 70 subjects, and we are about halfway. And we will give pamrevlumab as we have given in the phase 2 trial that was previously presented in PPMD meeting, the results, I think in 2019 pre-COVID, but it's 35 milligram per kilo IV infusion on day 1, and then every 2 weeks thereafter until week 52. We do have ongoing open label extension in the phase 2 trial, and we are planning on open label extensions in phase 3 trials. So the patients will receive 27 infusions over the course of the study, and they will be on steroids. So they will be on standard of care, and pamrevlumab will be given, this pure human protein, as an addition to steroids. And this was the outline. So it's 1-to-1 randomized, multi-center, global, double-blind. We have treatment arm, so pamrevlumab and steroids, and we have placebo. And then we have 27 infusions every up to 52 weeks and open label extension. And we have safety follow-up at 28 days, which is a visit, and then phone call at 60 days. These are the inclusion criteria, so 6 to 12 years, less than 12 years. And then predicted AVC about 45%. They have to be on stable dose of steroids, able to complete 6-minute walk distance test, able to rise from fall in less than 10 seconds, able to undergo MRI test of the lower extremity, and of course have confirmed diagnosis of Duchenne muscular dystrophy by validated genetic test. The exclusion will be up to investigator, of course, severe intellectual impairment, which may happen, it's rare, like severe autism or cognitive impairment, etc. Exposure to any investigational drug, whether it's DMD or not, 30 days prior to screening or within 5 half-lives of the drug tested. Poorly controlled asthma, underlying lung disease that's ongoing, like recurrent pneumonias, bronchitis, again, discretion of the investigator, etc. So primary endpoint is NSAA, change in North Star ambulatory assessment from baseline to week 52, and we have a series of secondary assessments. So change in 4-star climb velocity, change in 10-meter walk, run, changes in time to stand from baseline to week 52, and time to loss of ambulation. In addition, we have healthcare assessment. So we have, of course, treatment emergent adverse event testing, serious adverse events testing, and discontinuation of treatment due to treatment-related AEs, as well as we'll look at hypersensitivity or anaphylactic reactions. And we will also look at percent of hospitalization due to any serious adverse event with pulmonary, cardiac issues, and other after the first dose of the product. So it will be pretty comprehensive look on the impact of this drug on primary, secondary hospitalizations and safety. We have 11 countries. We are planning to open up to 65 sites. 45 sites are activated. As I mentioned, this is 7, but went up to 8, 5 activated, 8 in process, 2 in Australia, 1 in Austria, 3 in Belgium, etc. We have 30 sites in the United States. Wanted to mention, which I think is important for parents who are attending this conference, that in connection with Greenfire, we support patient travel, and that includes travel expenses such as meals, transportation costs such as airfare, train, car rental, taxi, gas to another city or even to another state, and overnight accommodations. If you want information, you can find it on Lelantus at fibrogen.com, clinicaltrial.gov identifier NCT 04632940. This is Lelantus 2 ambulatory patients. The accrual to non-ambulatory phase 3 registrational trial that was closed. We have here Jessica on the phone who has made many phone calls with parents who can provide information on the sites and logistical issues related to this trial. Thank you very much.
Grazie a lei, professoressa, per
Many thanks to you for this very valuable contribution. I would like to remind you that for those who would like to ask questions, there is a possibility of asking questions starting from now, and we shall then read them at the end of the session to the speakers. Now, let's switch to the 5th contribution. This is a study sponsored by FDA to have an intervention on myocardiopathy associated to DMD. Ines Macias Perez will be speaking, and this is a great pleasure for us. I would now pass the floor to this pharmaceutical company known as Cumberland Pharmaceuticals, and the molecule is ifetroban, now capable of blocking molecular signals, limiting inflammation mechanisms and the heart fibrosis. Many thanks, Ines, for being with us tonight.
Thank you, Sarah. Can you hear me? Okay, good.
Sì, la sentiamo, grazie.
Thank you. So yes, the organizers, I wish to thank for inviting Cumberland to this meeting. We introduced this study last year, and we're really excited to share with you all our progress since then. For those of you who are not familiar, my name is Ines Macias Perez. I'm Senior Manager at Cumberland Pharmaceutical. It's an emerging and specialized pharmaceutical company in Nashville, Tennessee in the US. We are developing ifetroban for multiple rare and unmet medical needs, and Duchenne is our newest clinical program. Let's see. All right, these are my disclosures. Cumberland is a publicly traded company. And for those of you unfamiliar with ifetroban, it was discovered and developed in the late 90s as an antiplatelet agent by Bristol Myers Squibb. It was tested in multiple clinical trials in cardiovascular disease patients. It's a selective and potent thromboxane receptor antagonist, which means it blocks the receptor from signaling on multiple different cells that it is expressed on, such as cardiomyocytes, immune cells, blood vessel cells, smooth muscle cells. It has several agonists that are all metabolized from arachidonic acid that could potentially activate it. And ifetroban as an antagonist basically blocks the receptor from activating regardless of the ligand that tries to activate it. We have completed up to 27 clinical trials, and many of those were in cardiovascular disease by Bristol Myers Squibb, but we've also done our own clinical trials in rare diseases and unmet needs like hepatorenal syndrome, portal hypertension, systemic sclerosis, an asthma study. And we've dosed up to 1,000 patients with or up to 1,400 patients with up to 1,000 milligrams with no serious side effects to date. We have completed 27 clinical trials and many animal studies, so the safety profile of ifetroban is well established. But this phase 2, called the FIGHT DMD trial, is the first to be done in pediatric patients, and it's also the first in DMD. So this is the mechanism of action where abnormal dystrophin or having no dystrophin has caused calcium irregularities that can then cause a lot of reactive oxygen species in the muscle of the heart and cause a lot of fibrosis and fat to deposit. So it's basically the scarring of damaged tissue that's being replaced from normal tissue. And this inflammatory response is cyclical, and it keeps happening over the life of the heart. Oops, sorry. See if I can go back. And then eventually causes heart arrhythmias, which is abnormal beating, and then heart failure. And unfortunately, it's the leading cause of death in DMD. And so our collaborators at Vanderbilt University in Nashville, Tennessee, was working on a mouse model of pulmonary arterial hypertension. And that model system essentially inflates the right ventricle with blood to then cause artificially fibrosis to set in, or the scarring of the heart. And they found that with ifetroban, they could prevent the cardiac fibrosis and cardiac dysfunction of pulmonary arterial hypertension. And Larry Markham, who is a pediatric cardiologist at the time at Vanderbilt, saw all our data and asked us if we'd ever looked at it in Duchenne muscular dystrophy, where they also see dilated cardiomyopathy or left ventricle fibrosis. So with the help of FIGHT DMD, or an organization, a local nonprofit, as well as with Cumberland, we both co-funded this preclinical study that you see here that was published in the Journal of the American Heart Association, where Erica Carrier and James West took different models of muscular dystrophy, the delta sarcoglycan, which is a knockout of a limb girdle model of a knockout of delta sarcoglycan. And then on the left are the survival curves of two Duchenne muscular dystrophy model system, the double knockout of both dystrophin and utrophin, and then the MDX modified telomerase mouse model. And essentially with all three model systems, they found the similar results as with the pulmonary arterial hypertension model, is that Ifetroban could prevent the fibrosis in the heart from settling in over time, as well as the cardiac dysfunction and mortality. So all the mice that were on Ifetroban survived, while the mice that were on vehicle control succumbed to the disease. On the top right-hand corner, in the open circles, are the vehicle-controlled delta sarcoglycan mice, where the ejection fraction decreased from month 3 to month 6, while the Ifetroban or the blue triangles were stable. So these results were so striking to us that we started the program, a clinical program for Duchenne, on top of the commitments that we already had with our other disease, rare diseases. And we decided to submit to the FDA an orphan product grant to help fund this additional program that we hadn't anticipated. We just felt very impelled by the data to move forward in this much needed area of research. These are additional slides from her paper, Erica Carrier's, where the hearts were with fibrosis, which is the red staining below each heart slice. And then it also was able to block TGF-beta, which is a signaling pathway responsible for fibrosis. And these are just the quantitative tables or graphs of the fibrosis that was quantified. Interestingly, as we were writing up the FDA grant and starting up the Fight DMD trial, independent of Cumberland and the Vanderbilt work, a research group led by Poonam Pagmar in Texas A&M had Ifetroban and was looking at coronary artery dysfunction in the MDX or the DMD animal model. And she took coronary arteries from young mice that had dystrophin and young mice that had DMD, and were treating them with the agonist for the thromboxane receptor, either in the presence or absence of Ifetroban. And she essentially was able to see that there was coronary artery dysfunction in the DMD mice, but when you treated them with Ifetroban, you could stabilize that and prevent that abnormal dysfunction of the coronary artery. Now, for those of you unfamiliar, the coronary arteries are what supply the cardiac tissue with blood. And so this is very important to keep the heart of health maintained. And then on the right, she took aged mice or older mice that had either normal dystrophin in the heart or they lacked dystrophin. And she was able to also show that there was coronary artery dysfunction in the aged mice, whether they had DMD or normal dystrophin. But either mice, when treated with Ifetroban, was able to normalize or prevent that coronary artery dysfunction. So she reached out to us with her data as it was accepted to let us know, because she was aware of our Fight DMD trial and just wanted to make us aware of this striking and supportive evidence. So as I mentioned, the Fight DMD trial was given its name because of the Fight DMD organization. It's a nonprofit that was started by Terry Marlin because he has two boys, Jonah and Emery Marlin, who were diagnosed several years ago with DMD, and there was no treatment at the time when he came to Vanderbilt. So we were very grateful for his support and their organization. And so we gave our first trial in DMD the name the Fight DMD trial. And as I mentioned, because we hadn't planned on a DMD program, we submitted an FDA orphan product grant. That organization within the FDA is specific for rare diseases or diseases as they define them as less than 200,000 patients per year. And they'd never yet provided a grant for DMD. So we were quite surprised and felt very optimistic about our chances, given this was very striking preclinical data, and it's an oral medication. We thought it would be, and a lot of supportive safety data already established over the years. And so we were fortunate enough to have been granted the first orphan product clinical trial grant for an orphan product. So this is the inclusion criteria, and it's very open because, as I mentioned, we're focused on the heart. And so our primary endpoint is using cardiac MRI, and we accept both ambulatory and non-ambulatory DMD boys 7 years of age and older, any mutation status. They may be on any cardiac medication as long as their cardiac function is stable. They should have a left ventricular ejection fraction of 35 or greater. That could be using echo or CMR. They can be on any FDA-approved exon skipping drug, any stable corticosteroid. They could also be not on a corticosteroid if they choose. They could have, as I mentioned, any cardiac medication allowed, like an ACE inhibitor, beta blocker, as long as they've been on stable dose for at least 3 months. And also, as I mentioned, any exon skipping drug or ARA. These are a few of the exclusion criteria. I won't go through all of them, but essentially our study is as open as possible so that we can focus on the heart and hopefully see an improvement or an impact in it over 12 months. Our drug is, as I mentioned, oral, but it must be taken in a fasted state. Food effect studies have been done. And they have all demonstrated that there is a large food effect, whether it be protein, carbs. So the drug must be taken in a fasted state. We're aiming to enroll 48 DMD boys 7 years of age or older, and we stratified them into 2 cohorts. We're looking at patients with early stage cardiac disease and those late stage. Late stage is defined as 35 to 45% left ventricular ejection fraction, or any, and early stage is anyone with LVEF greater than 45%. We're also looking at 2 doses of ephedrine, a high dose and a low dose, which is weight-based. So again, there's a 2-to-1 randomization to receive ephedrine. We are doing PK studies, but they're not with multiple draws. It's with finger stick method. And ephedrine, as I mentioned, we'll be looking at oral ephedrine versus placebo for 12 months. There's 3 visits. We tried to keep this with the standard of care visits to not add travel as a burden, although we cover all travel costs and try to facilitate that for the families. There is an open label extension for all patients that complete 12 months of treatment. And since I last presented in February of last year, we had 4 of our 10 sites open, and we received a COVID supplement that allowed us to add 6 more sites to hopefully improve our reach of DMD patients so they don't have to travel as far. So in 2021, we opened 6 new sites across the US for this first phase 2 study. And we also enrolled 26 patients during 2021. So we now have a total of 27 patients on the Fight DMD trial of the 48 that we're aiming for. So we're really excited about this progress. COVID has been a hardship on everybody around the world. Clinical research basically stopped. But our families with DMD were very motivated, and so were our sites to reopen as quickly as possible. So I wish to thank all the families and the sites for their motivation and their engagement. Our study coordinators are phenomenal. Our primary investigator, Larry Markham, our co-PI, John Soslow, and all the organizations that have helped us thus far.
Grazie mille Ines per il suo intervento.
Thank you, Ines, for your intervention. And we close now with the last intervention. CAP 1002 with Linda Marben, who is President and CEO of the American company Capricor. Linda will be speaking about CAP 1002. It is a cell therapy. It is an innovative experimental cell therapy based on the administration of cardiac stem cells derived from the cardiac tissue of a donor with a method that has been prepared by Capricor. You have the floor. Thank you. Thank you for being here with us tonight.
Thank you so much for having me. I look forward to attending this meeting in person next year and hope that the world normalizes. I'm going to be talking to you about CAP 102. We are a publicly traded NASDAQ listed company in the United States of America, and all of our filings are up to date with the Securities and Exchange Commission. Well, since I've last presented, and in fact, very recently, we have moved our company headquarters from Los Angeles to San Diego, California. That is in part due to the expansion of our program with an exosome platform in preclinical indications, but also to support the advanced clinical development of CAP 1002, for which we are entering a phase 3 registrational clinical trial, and also based on our partnership with Nippon Shinyaku, better known in the US as NS Pharma, to further develop CAP 1002. And I'm happy to take any questions about that. Please, if you're ever in San Diego, do come visit us in our beautiful facility in Road to the Cure. Let me talk to you a little bit about Capricor cell therapy. Unlike what many people might think, this is not a stem cell therapy. It is a cell that is called a stromal cell. It's a very special kind of cell that is held within the heart of all people. What we learned to do now about 15 years ago, and many of you may not know this, but this was in collaboration with our teammates at the University of Roma La Sapienza, where the original discoveries were made of the cell therapy. And we were then able to isolate out those cells, grow them up, and now have done around 7 clinical trials of CAP 1002, 3 of them in Duchenne muscular dystrophy, and now we're starting our phase 3. The way the cells work is by secreting something called an exosome. An exosome contains RNAs, non-coding types of RNAs and proteins. They're taken up by target cells and they change cellular behavior. Primarily, they are anti-inflammatory and they are also regenerative. That means they drive natural muscle cells back into the cell cycle and allow healthy new muscle to be created. And the cells have been in about 200 patients to date, so we know that they're very safe with a really strong safety profile. For now, we are targeting those later stage Duchenne patients, those that have a loss of ambulation. We have been working with those patients since Hope Duchenne, our first clinical trial, primarily focusing on those folks that have also an established cardiomyopathy in our early clinical manifestations, finding that the cells not only worked in addressing the cardiomyopathy associated with Duchenne muscular dystrophy, but also in helping to repair and restore skeletal muscle, stabilizing the decline of these really highly needy patients. So we are excited to offer an opportunity to those for which very few medically driven options remain. Of course, we plan on expanding into the younger children in the next few years as we achieve registration for CAP 1002 in the later stage patients. I'm going to very quickly review for you the clinical progression of CAP 1002 in Duchenne muscular dystrophy. As I mentioned, we started in the space doing a relatively small phase 1-2 study. It was a 25 patient study, randomized and open label. At the time, we were addressing primarily the cardiomyopathy associated with Duchenne muscular dystrophy. And so we were delivering the cells right to the coronary vasculature, 75 million cells. All of our patients were on stable corticosteroids. And as I mentioned in the previous slide, there are very few options for this patient population. What we found was really exciting and really kicked off our entire clinical development program in Duchenne muscular dystrophy. Using MRI and a special dye, which we heard about in the last talk, called gadolinium. We were able to measure that scar, the amount of damage done to the heart, was reduced both at 6 months and 12 months in those that were treated with the cells versus those that were not treated by the cells. We also saw an improvement in cardiac function in this particular trial. It was called systolic wall thickening, that basically is the ability of the heart to contract. And it was measured in certain places in the heart near where the cells were delivered. And this was also at 6 and 12 months. And then most importantly, we showed improvements in the performance of the upper limb, specifically in the mid plus distal, so the arm and wrist and hand. And while we delivered the cells in this clinical trial only once, we were able to see over the course of the year that the best improvements of the performance of the upper limb was shown within the first 3 months. And that informed our dosing paradigm in multiple ways moving forward, which I'll talk about on the next slide. The study was published in the Journal of Neurology in 2019. So the study that I just spoke about, Hope Duchenne, informed HOPE-2. HOPE-2 was a larger trial in its initial derivation. It was randomized, double-blind, placebo-controlled. We selected now those patients with DMD and reduced skeletal muscle function, those that were either non-ambulant or processing towards that. We removed the inclusion-exclusion criteria of cardiomyopathy, both for ease of the patients, but also because we were able then to focus on the more measurable impact, which is ambulation or skeletal muscle function. Based on the data collected from Hope Duchenne, we realized we wanted a dose every 3 months. That required us to find another delivery method besides intracoronary or in the heart. And so we then backed off to intravenous delivery. So very simple IV delivery. The patients get this every 3 months. It's 150 million cells. Delivery takes somewhere around 45 minutes to an hour. We usually give the boys an iPad. They can play a video game or watch a movie. And with very few reports of any side effects, the kids do just fine. And are able to go home. The mean age of these patients was 14.3 years, and they were all on steroids. That's one of our requirements, so that we give the best that medicine has to offer, and any improvements we see are on top of that. And most of our patients were regularly dependent upon a wheelchair. What we saw was absolutely extraordinary, and I'd actually like to highlight the fact that Capricor was one of the very first companies to really take full advantage of this very important method called the performance of the upper limb. Many of our colleagues, and you've even heard them here today, have adopted using the performance of the upper limb as a measurement of upper limb function. Partially, this is because, I hope, of our data, but also likely because it's such a good measure of those patients that are not able to, for instance, complete a North Star ambulatory or a 6-minute walk test. The performance of the upper limb, the first version was called the 1.2. It's now moved to the 2.0. It's kind of like your smartphone. Later versions have improvements to it. And what we saw is statistically significant improvement in the performance of the upper limb in the treated patients versus the placebo patients. And these are direct placebo patients. They're not natural history controls or patients that are followed alongside. These are patients that are coming in and without knowing it are getting either basically a placebo injection of our buffer or our buffer plus the cells. And what was also important is that we saw 1.8 point improvement in the CAP-1002 treated patients versus the placebo patients after a year. That's very statistically significant, as you can see, but also clinically relevant. What we've determined is that a 1-point change really is sort of a benchmark of the establishment of clinical relevance. So we are very enthusiastic about this data and has led us obviously to the design and now the initiation of a phase 3. What's even more important, and I think you've heard here today, is, we're beginning as a space to laser focus on the heart. Capricor was actually early to that game, thinking that working on the cardiomyopathy associated with the Duchenne muscular dystrophy would be of great importance because we know that that's ultimately what can cause determination of life in those patients with Duchenne muscular dystrophy. Left ventricular ejection fraction is the most important clinical indicator of cardiac function. It's sort of what tells your physician how the heart is meeting the needs of the body. Our patients get a baseline MRI. They have no gadolinium dye. We're just using the straight imaging. We didn't want to put dye back into the patients. We knew scar size was reduced. And again, what we saw is a marked improvement in ejection fraction compared to the placebo patients, very statistically significant and very clinically relevant. If we can hold these boys and young men to an improvement in ejection fraction or even a stabilization of ejection fraction year on year, it could be life extending in terms of quality and quantity of life. In addition, if gene therapy really takes off, we also will be in a great position to help those boys and young men because their bodies will be able to do more, their hearts will be asked to do more. So stabilization of ejection fraction and cardiac function will be of great relevance. Now, we also were able to show statistical and significant improvement in a biomarker called CKMB, creatine kinase MB. This is specifically seen in the heart and only measured in the blood when there's heart damage. The guys that got CAP-1002 had less indications of cardiac damage than those that were in the placebo group. Taken together, a strong picture of skeletal muscle improvement and cardiac muscle improvement. This paper will be published within the next few months in a major journal in our field. It's already been accepted. We're just in the queue for publishing, and I'll make sure the community is well aware of that at the time so that you can be aware of all of the data from the HOPE-2 clinical study. So let me just summarize what I just saw and just showed you, because I think it's very important that you understand the relevance of this clinical trial in Duchenne. This was the first placebo-controlled trial showing upper limb functional improvements in non-ambulant DMD patients. We saw directionally consistent improvements in strength, respiratory, and cardiac endpoints. That's available on our website in a larger presentation, as well as in the upcoming publication. We're the first ever study in Duchenne muscular dystrophy that correlates cardiac functional stabilization with reduction in the biomarker CKMB. And we've shown results very relevant and consistent in a preclinic phase 1, phase 2, and a phase 2 study, as well as an open label extension. And we now are in expanded access for our HOPE-2 patients, because literally families call us daily asking us to please make sure their sons stay on CAP-1002 as they're doing so much better on it than off of it. And there's also some videos of those patients in the open label extension on our website. There were 69 infusions that were performed. It was safe and well tolerated. We had some early stage hypersensitivity reactions, which was completely attenuated by pre-treatment with some oral steroids and antihistamines, so very easy. Very quickly, we're starting the phase 3 clinical trial. We have sites that are getting up and running imminently. It's going to be a randomized double-blind placebo-controlled trial. We already have had feedback from the FDA on this trial. There will be 70 patients. We're anticipating 25 US-based sites, exactly the same patients as HOPE-2. Why mess with what works? Those primarily non-ambulant or nearly non-ambulant. The primary endpoint will be the performance of the upper limb 2.0 at 12 months. We're also going to be measuring cardiac function and quality of life and clinical status using the Duchenne video assessment strategy. And, we'll provide an open label extension, of course, for those patients that are kind enough to put themselves in this trial. We recently announced a very exciting deal with Nippon Shinyaku. The US company is NS Pharma. They have an exon skipping therapy that's approved. It's a great partner for Capricor. We were waiting for the right partner. We looked for the right partner. It has a total deal value of $735 million. But the most important to you is that there's $30 million up front. I said I wasn't going to start this trial until I had the money to do so, and now we do. And there's a lot of other bells and whistles that are good for the company. company, but mostly what's good for the patient community is that Nippon Shinyaku or NS has an established sales, distribution, and marketing program. They work well with CMS for reimbursement, and so we feel like we're going to be in good hands. Capricorn's doing all the clinical trial work, so it's the same old group doing clinical trial work, delivery of the drug, filing for approval, and then NS will take over at sales and distribution. And that is all I've got for you today. I want to say thank you, not only to this wonderful meeting, but really to the patients and to the families that have given us the opportunity to test CAP-1002. And also, I want to say be patient, those of you that are emailing me, calling me, and asking for CAP-1002. We're working as fast as we can with the regulatory agency to get approval as fast as we can and get your sons in our trials. So thank you today, and I look forward to talking to you soon. Thank you.
Grazie mille.
Many thanks. Thank you, Sarah. And thanks to all of the speakers. Special thanks to the speakers who woke up so early today in the Pacific coast of the USA, and in general, all of those who are attending from the USA. So heartfelt thanks. And here, let me introduce one of the three biologists of the scientific office, Ilaria Zito. She's sitting close to me, next to me. She's in the Starship. And we shall also have another surprise later on. But now, the floor to Ilaria. She will read the first question. Many thanks. We know that we have so many questions that did come in. The first one is this one for Eric Kaufman. Is there a study which is comparing vamorolone and Delazacort, showing that Delazacort is more effective than prednisolone? No, this was a statement, sorry. The question was, what is your opinion with that respect?
No, there's no study that's been done comparing Deflazacort directly head-to-head to vamorolone. So and one is not planned at this point.
Okay, grazie.
Many thanks. Thank you. Next question. Again, this is for Eric. When vamorolone is administered to a young boy who has already received the eplerenone for the heart condition, the patient or the parents of the patient are wondering whether the dose is going to be scaled down somehow, and whether vamorolone is requiring any regular controls of potassium levels, just like the eplerenone.
Well, first, we have been studying potassium. We've been studying potassium levels in all the trials, and so far haven't seen any abnormalities of those. So at this point, there doesn't seem to be that. And I think even with the eplerenone, it's only a subset of patients that show that. That's a very good question about co-administration of eplerenone and vamorolone, because they do seem to have overlapping functions. To date, the trials have been in young patients. And as you know, eplerenone and spironolactone aren't usually used until much later teenage years. So at this point, we do have an exclusion criteria for MR antagonists like eplerenone and spironolactone, but it really hasn't been an overlap. What we hope to do is there's now patients that have been on vamorolone for 7-8 years and are now entering the stage where cardiac MRI should start showing abnormalities. So we hope to bring all those patients back for cardiac MRI and compare them to prednisone and Deflazacort treated kids. That's currently planned, but not yet underway.
Bene, grazie. Continuiamo sempre con Eric Kaufman.
Still for you, Eric. Kaufman. This is coming from an anonymous participant. In part, you have already answered, but he is also asking whether comparisons were made between deflazacort and vamorolone. We've already said no. And he's also asking whether all of the studies were based upon prednisone as a reference drug.
Well, to be clear, we've done comparisons of vamorolone and deflazacort in open label studies. So those are published both for Synergy, the CINRG DNHS study, as well as for the Trans UK North Star network. So in that context, many patients are taking deflazacort, but they're not head-to-head comparisons. So in other words, in a double-blind trial at the same time. So those published studies that are open label and have compared deflazacort and prednisone in real world data have shown very similar efficacy regarding vamorolone versus standard of care. And that's that data I showed in the presentation, and that's published in a couple publications. It's just we haven't done a head-to-head in a double-blind study.
Ok, grazie.
Thank you. This is Alberto asking, still to you, Eric. Would you say that vamorolone could be administered for a longer period and then also still bear positive effects for adult patients and even for non-ambulant patients?
Well, the short answer is we don't know. Haven't yet done those studies. As I mentioned in my presentation, we're enrolling 7 to 18-year-old boys either on steroids or off steroids in a Canadian trial in 6 sites. And that's funded by Jesse's Journey in Canada. So that will begin to get that data, but at this point, we don't know.
Le prime domande evidentemente sono arrivate tutte nel primo...
The first questions came with respect to the first presentation, but we still have another question for you, Eric Kaufman. And the question is, having seen the results, is vamorolone being submitted to regulatory agencies for its marketing? Did I understand well, hopefully?
Yes, we've already met with the US FDA, and they have suggested that our existing efficacy and safety data is sufficient to submit a new drug application. So as you know, you put together a very large package of information and submit that, and then the agency has to review that over many months to determine if they will provide a drug approval. So that submission starts next month and will to put in all those modules, and then FDA, depending on how long it takes, it'll probably be early next year where there may be their decision. For EMA, for Europe, we similarly prepare with Santhera. This is all in partnership with Santhera. So they're taking the lead, I should say, on the regulatory submissions. That is also planned for this year, this submission.
Bene, bene, questa è un'ottima notizia. Quindi ci terremo in aggiornamento su questo. Prossima domanda.
Fine, we'll keep you updated. Then we have a question for Annabelle. Or rather, we have more than one. Let's get started with the first one anyway.
So the response is we commenced establishing the study in Europe following the positive opinion that we've had for our pediatric investigational plan from PEDCO and the EMA. So that covers our full program. So, however, we do continue to look at future plans for 1102 and certainly opportunities to open the study in other countries, and that does include Australia.
Ne approfitto per chiederti...
Let me take advantage of what you just said, and I would like to ask you something else. You did make mention of CTI Italia for the future.
Yes.
And hence, we would like to know whether you could give us any more specific indications as to which clinical centers in Italy.
We're still finalising our clinical trial list at the moment, well, the site list. However, we are looking at probably around 4 to 5 sites in Italy, and we're certainly looking at wanting to get a good geographical distribution across Italy to make the study as accessible to as many families and boys as possible.
Grazie, infinite. Ilaria.
Many thanks, 1,000 thanks. Now a question for Paolo Beffi, Alberto Bottaro, whom we greet. The question is, when you think to submit the same request to EMA for possible marketing, now given the data and given the studies that have been accomplished, what are we still missing? So we are still missing the completion of the statistical analysis, which is not something that you do just overnight. We envisage having new results by the month of June. And the goal or the objective is the one of submitting the request by end of year or at the latest by January next year. Very well. Another question that is for Eric, coming from Costantino, who states that one of the problems of having access to the drugs on the different health services and insurance services is they are extremely elevated and high cost. Now we've seen how the Flazacort in Italy, coming at the cost of 1,200, has been accepted in the USA at the cost of 80,000 euros, which is 70 times more than the average cost in Europe. Now, in view of the marketing, Costantino asks you whether you have considered the cost factor and how much could it eventually in the end cost. This is an important issue that Costantino is raising.
The short answer is, well, first, Santhera is responsible for cost negotiations. As you know, those through the HTA process are individual negotiations with each country and take some time. It is different in the US, where it is much more of a free market system where the regulators really have very little or nothing to do with pricing, but rather just approve the drug and put it into the marketplace and see what the market will bear. So that's why you see the very different pricing of US drugs versus other countries, because of our lack of nationalized healthcare system and the lack of negotiation. So I really don't know what this will cost.
Ok, quindi staremo a vedere.
We shall wait and see then. This is a question for Linda Marban, again coming from Alberto Bottari. He is asking whether there is an intention to expand the use of CAP 1002 to younger patients that are still ambulant.
Yes, absolutely. In fact, we have some really nice preclinical data that suggests that disease progression can really be attenuated if it is started at a younger age. However, our current plan is to complete HOPE-3 in these later stage patients. And then once we achieve registration of CAP 1002 for that particular population, then to do label expansion studies for the younger patients. We wish we could start younger now, but unfortunately, the regulatory bodies make you do this in a stepwise fashion.
Ok, già che ci siamo, eravamo anche curiosi di sapere.
We were also curious to know whether the phase 3 trial is going to include Europe and possibly Italy.
Yes, so obviously we would like to be in Europe, and we are currently evaluating opportunities as to whether to be expanding in Europe with HOPE-3 or right on the heels of HOPE-3. A lot of that will have to do with site initiation, how quickly the trial enrolls. But of course, we would very much like to see CAP 1002 not only tested in the EMA vicinities, but also approved for worldwide use. Thank you.
Grazie a te.
Grazie, Linda.
Thank you, Linda. Another question, but I believe that you have already answered, but let's stress again this very important step for your own company, which is that you signed in for a partnership agreement with the NS Pharma for the marketing in the USA. And a participant is now asking what will then happen in Europe, thanks to the agreement that you just underwrote in Italy, and what are the new possible evolutions for Europe?
Yeah, thank you so much for asking that. So currently the partnership with NS Pharma is for US rights only. We are still actively looking for a European or partner for other parts of the world, obviously, which includes Asia and Europe, Australia. And so, you know, we are seeking that. And if we find the right partner, we can move even faster towards obviously getting CAP-1002 into Europe.
Grazie, grazie infinite Linda.
E facciamo
Thank
adesso...
you, Linda.
Thank you.
Grazie. A Eva.
Now a question is for Eva. And I don't know whether there was also Jessica available to answer the fibrogen questions, but Eva is okay. She can answer as well. The question is, when will we see the availability of the early results having to do with the trial conducted on the non-ambulant patients?
Oh, thank you so much. Do you hear me? So first of all, we are preparing for publication the phase 2 trial that was on a smaller trial, 21 patients. We presented this data before for PPMD, and I hope that we can publish this year, so you will see this data. The non-ambulatory, we just finished accrual, so the patients are still receiving drug, obviously. So we are not there yet to it probably will be 2023 at least. End of 2023 that we'll see any data.
Ok, grazie. Quindi aspettiamo giustamente.
So thank you. So first we have to wait for the previous trial.
Yeah,
Next
this
question.
is finalizing the manuscript, yes. So you will see it probably this year.
Ok, perfetto. Abbiamo un'altra domanda per Linda.
Another question for Linda. Considering the improvement in the upper limb test and muscles, can we assume that the cardiospheres are going to behave like, how can we say this? Like a sort of homing in the skeletal muscles and in the heart muscle. I don't know whether you could understand me, Linda. She said the question, she mentioned the question in half Italian, half English, so I'm not sure I understood it, but anyway.
So she can provide clarification, but what I think she's asking is, are the cells actually going to the skeletal muscle or going to the heart muscle? And so this is a really great question, and one that I want to take on because it's very important for the community. So the cells work by releasing exosomes, as I mentioned. The cells themselves are gone definitely in around a week. At least in preclinical models, we really don't see nearly any cells left after a week. Most of them are gone within the first couple of days. What they do is when they get into the circulation, they embed themselves into the very small blood vessels in the respiratory system. But don't worry, they don't cause any safety events. We've even done a full clinical trial in patients with severe COVID with respiratory compromise, and we've never seen even the slightest hint of a respiratory complication. There's a lot of very small blood vessels. When the exosomes are released, they travel typically to sites of injury. They have natural homing devices to sites of injury where they're taken up by a cell called a macrophage, which is like a white blood cell, and they simulate an anti-inflammatory cascade of events, shutting down inflammation, which everybody knows is one of the most major components of injury in Duchenne, which is why steroids work. And then that allows the muscle, once it's cleared of the inflammatory process, to be able to start repairing itself with an endogenous population of their own stem cells. So it allows the muscles to stabilize and to stabilize function. So it doesn't create new muscle specifically where there was none. What it allows is that the muscle can heal itself. I hope that answers her question. So to finalize, the cells do not persist or home themselves.
Ok, grazie. Credo che fosse proprio questa la domanda.
Yeah, I believe that this was exactly the meaning or the sense of the question. Again, Linda, another participant, is asking, in the HOPE-2 study, 80% of the patients were non-ambulatory patients. How were assessed the ones that were still ambulatory? How did you evaluate them? Were you using any assessments with regard to the ambulatory function in patients that were still ambulatory apart from the pool?
So when we did the original clinical study called Hope Duchenne, we indeed did. We had the 6-minute walk test as part of our endpoints. But what we found is that the patients that had the established cardiomyopathy really were either unable to complete the 6-minute walk test or really had very poor performance. So we've removed most ambulatory assessments or all ambulatory assessments from HOPE-2 and now HOPE-3. The entry criteria requires a reduction in torso strength, and so is based on criteria from the performance of the upper limb as opposed to ambulatory assessment.
Ok, grazie Linda.
Grazie Linda, abbiamo le ultime 2 domande per Ines.
Thank you. Now we have 2 questions for Ines. Another participant is asking, on the basis of data obtained out of mice, the mice population, can we hypothesize a different effect on different muscles, different from the heart muscle, I mean? And then the next question is the following. Another participant is also asking, or saying rather, that he was astonished by the very broad inclusion or entry criteria. So he would want to know what is the primary endpoint of the study. Thank you.
My pleasure. Thank you for your questions. So the primary endpoint is left ventricular ejection fraction using cardiac MRI. It's a research protocol. So it's looking at also parameters outside of the standard of care cardiac MRI so that we could look at earlier signs. We're looking at biomarkers that could be helpful, looking at earlier markers of improvement so that we don't have to use left ventricular ejection fraction, which oftentimes declines rather quickly and then might be too late to help stabilize. So that's why we're looking at 2 different patient populations, the early stage where we might be able to show improvement, and in the later stage that have advanced disease where we might be able to stabilize due to so much fat deposition and fibrosis or scarring that might be already present. And the reason for the broadness is because we are focused on the heart. We're looking at secondary endpoints such as quantitative muscle testing, daily activity using actigraphs, because if the heart health is better, then you may potentially see more activity in both ambulatory and non-ambulatory. The actigraph is worn like an Apple Watch on the wrist. So hopefully if their heart health is better, then they're maybe more active. And then we're looking at quantitative muscle strength to see if maybe there is improvement there as well. So there are secondary endpoints in addition to the standard cardiac MRI as our primary endpoint.
Grazie, grazie Ines per le risposte.
Thank you, Ines.
Di questa ultima sessione.
I wish to thank once again the rapporteurs of this last session. Thank you, Sara Capponi, who is a member of our board that co-chaired the meeting with us. Thank you, Ilaria. Thank you, Fernanda. And I wish to thank all participants who asked excellent questions, and families even asked questions in English, and we had to translate them into Italian, and interpreters translated them the other way around. So thank you to all our families. Now all around us there are things happening. Beware. There we are, all here, all on the spaceship. But our journey has been going on for 25 years. Next to me, Fabiana Boccia, project area, Fabiana Ruggero, who together with the service has guided our journey, Patrizi, Fernanda, and from home we have all the other members of parent project staff and also the members of the board. I can't see our president. He's supposed to be there. He's there somewhere. Hello. Now you got a camera on you, and before saying goodbye, if you want to say goodbye from the earth, we'll say goodbye from space, from open space. Very rapidly, I wish to thank all of you for the success of this extraordinary international conference. We have had extremely important moments, and we are really very, very glad. And we'll be listening to the recorded sessions over time. This is an advice for all the families. A big hug, and well, I do hope to see you all again in February 2023, face-to-face. And in closing, we thank our interpreters who have been following these 4 days and have made it possible for our conference to be international. So a big hug to the interpreters and real heartfelt thanks. There we are. Here is Carlo. Here is the technical service. They really supported us with great goodwill and great expertise. Thank you. We have, well, special thanks to the companies that have supported our conference. We have Ital Pharmaco and PC Therapeutics and the Platinum sponsors, Sarepta Therapeutics, but also all the other companies that have made it possible for us to organize this event. We thank all the speakers that were connected with us from all over the world, some of them very early in the morning. And thank you the families, thank you to our boys. And now, before saying goodbye, well, all together, we have a special message, because our message goes on, and it goes, there we are, ready? Well, our journey can go on only if you go to the website and you remember to donate, because otherwise our spaceship will collapse. You must remember to go on donating, and then ready, steady, go. Don't go away, because there will be a conclusion that is a surprise for us all. To the infinite and beyond. See you next year. face to face, hopefully. Don't go away. Don't go away. We have beautiful music at the end.
Buon pomeriggio. Benvenute e benvenuti sulla nostra navicella spaziale, dalla quale stiamo per iniziare la 19ª edizione della Conferenza Internazionale di Parent Project. È vero, avremmo voluto incontrarci di persona, perché quest'anno ci avevamo creduto, eravamo pronti, ma quindi per superare la tristezza di non esserci visti, Filippo, che 25 anni fa ha iniziato questo viaggio.
Filippo, 25 years ago, started this journey and is still continuing this journey with new routes. Well, he decided to go to the space. For us, the scientific activity has always been something very important. Certainly, living with Luca has made me a person that I essentially like. My personal conclusion is that you are all special boys with disability and siblings. Well, thank you for what you said, Cristina, because since the very beginning, since the diagnosis, we opened up to the world with a smile, and that is what I noticed. Well, I've spoken smiling because I keep smiling. You and your family set an example for us all. I wish to thank Daniele Bianca, very serious, very responsible, and also very pleasant. And these are things that are useful for us all, boys, parents, and also carers. What I repeat to myself and also to others is the first step is accepting, being aware that this disease is present, but the most important aspect is, well, Samuele comes first, Jacopo comes first, and all the other boys, and then there is the disease. First of all, they are persons like us. We must not consider them only as boys with the MD. They are boys. They are boys. They are persons like any other person, and this is the essential key. I mean, you must not consider disease before considering the person.